mentor for ISU and IMS MAST, runs Minimal Access Training Institute for training urologists, author of bestseller Coffee Table book on RIRS and flexible uteroscopy book, published many articles in international journals. So with this introduction, without wasting time, we will ask the first speaker, Dr. Kiran. May I request the moderators to take over the session? Dr. Manohar, Dr. Deepak, one by one you decide, and then if possible, you can introduce the speaker. I will project on the screen if you required. Thank you. Over to you, Dr. Deepak and other moderators. Thank you. One of you start, please.
Thank you, sir. Thank you for the brief info. And with the brief introduction, I think we'll go ahead and start the session with the first talk. Yeah. And if there's an intro, I would like to.
We have the introduction. You people introduction I might have done. Just I will quickly go through. Dr. Manohar is the moderator today, who is presently professor in Institute of Nephrology and Urology. He has interest in endourology, laparoscopy, and renal transplant. He is past secretary, Bengaluru Urology Society, past council member for Karnataka Urology Association, and he has 30 publications. Dr. R.M. Satish Kumar, MS MCH, who was my junior also and friend, MBBS Stanley Medical College, MS Stanley Medical College, MCH PJ MER. He has interest in uro-oncology, laparoscopy, and also RIRS. Consultant urologist, Apollo Specialty Hospital, Madurai. Head of the department, Velamal, also previously. Now he has his own hospital, Sandeep Memorial Hospital. Dr. Deepak Raguri, who is MBBS from JJM Medical College, MS in General Surgery, JSS Medical College, MCH in Urology, Ramchandra Medical College. He is Senior Consultant and Facility Director, Asian Institute of Nephrology and Urology, High-Tech City. His areas of interest are primarily endourology, more so in stone and prostate disease. His experience is 15 years plus, and he is currently heading the unit. He is also into research and training, especially training the urologists, various types of flexible scope and laser. I have published over 50 articles in both national and international journals. Rajnikant, who is MCH Urology from Medical College Trivandrum, consultant urologist, Renai Medicity, Kochi. Areas of interest, HOLEP, RIRS, and laparoscopy. Is Treasurer Urology Association of Kerala. Now, Dr. Deepak, for your information, Dr. Kiran CV is projected on the screen.
Thank you, sir. Thank you for the introduction of us as well as moderators. So, considering we have 4 moderators, for the session today, I'll take over for the first 3 talks and then pass on to my colleagues for the subsequent moderation of the talks. So, 3 talks per head, 4 of us, we would be able to cover 12. So, to start with, the first talk will be given by Dr. Kiran. He's a senior consultant from the Nephrourosciences and Kidney Transplant Unit, Calicut. Over 10 years of experience and expertise in kidney transplants as well. And he's also well versed with his laparoscopic surgeries and HOLEP being his special area of interest, andrology and infertility also in the gambit. Experience of working in a specialist kidney transplant team and has performed more than 1,000 transplants till date. I think it'll be a fit for him to speak on endourology, considering predominantly he's a transplant surgeon. He'll be speaking on applied anatomy of the ureter in RIRS, a very apt topic to start off for the day, considering we're doing from A to Z. Over to you, Dr. Kiran.
Yes, sir. Sharing is not turned on. Host isn't allowed sharing. It's messages.
Kiran, you wanted to help? We will share if you have presentation. We are making you co-host. Sorry for that. We'll make all of you co-host who are presenting. Okay. Please stick on to the time. I know you people know very well. You are seniors.
Yeah,
you can share the screen now. You can share the screen now.
Okay, thank you.
Thank you. Next person co-host.
So thank you, Chandramohan sir, ASU, for giving me this opportunity. Good evening, dear senior colleagues and friends. So, topic for me today is applied anatomy of ureter in relation to RIRS. So, we'll be going according to the RIRS endoscopic landmarks, which we see while doing RIRS. So it goes without saying that a detailed understanding of renal and ureteric anatomy is very valuable for any endoscopic procedure, including RIRS. So from the meatus and urethra,
A little louder, Kiran. A little louder, Kiran.
Okay, sir.
Check. All right.
Am I audible, sir? No?
Yes, Dr. Kiran, you are audible. Just be a bit louder. That's it. Yeah.
Okay. So for the meatus and the urethra, it's not an issue. So RIRS because now because of so much of miniaturization of scopes and the urethra being 18 to 30 French, there's not much a problem for RIRS in case of meatus and urethra being 18. Then what we see is the trigone, which is the most vascular and deeply colored than the rest of bladder. And we see the Mercius bar, the interior heads, and on either side the ureteric orifices. So tip for identifying the ureteric orifices are the prominent mucosal vessels, which goes medial, inferior, and lateral to the orifice. So Lyon et al. Has classified ureteric orifice anatomy into four: the cone shape, this one, and the horseshoe, golf hole, and the stadium. And while doing endoscopy or cystoscopy, as we all know, as the bladder fills, the ureteric orifices are pushed laterally and the intravesical ureter comes. So the ureteric access is more difficult. So we have to keep the bladder decompressed. Coming to the ureter anatomy, the adult ureteric length is around 22 to 30 centimeters. It is 25 plus or minus 3.5 centimeters. The right ureter being 1 centimeter shorter than the left. And the normal diameter of the ureter is around 3 millimeter, 6 to 12 French is the range. So 96% of patients have native ureter less than 9 French, that is 3 millimeter. That's why miniaturization of scopes is in vogue now. And ureter has a accommodative and functional flexibility, which allows serial dilatation passively, and they dilate with stenting also. So while doing ureteroscopy, you have to respect the peristaltic physiology and wait for the relaxation before introducing the scope. You should avoid pushing against the contraction to prevent mucosal trauma and perforation. So what are the properties of ureteral wall structure with special implication for ureteroscopy? So ureter wall, as you all know, has 3 layers: mucosa, musculosa, and adventitia. In the distal ureter, submucosal tunneling and false passage is more common. Why? Because the transitional layer is more redundant and bulkier, but with a thick muscular backing. Hence, the perforation is less, but submucosal tunneling and false passage is more in case of distal ureter. Whereas in the proximal ureter, ureteric perforation and avulsion is very much possible because of less muscle wall support. So beware of forceful scope introduction, especially in the proximal ureter. Divisions of ureter, we all know the classic 3-segment division, starting from the pelvis to the upper border sacrum, the sacrum to the lower border of sacrum is the middle ureter, and the distal ureter from lower border of sacrum to the bladder. There is another division given abdominal ureter, pelvic ureter, and the intramural ureter. So these are the endoluminal ureteral course while doing RIRS. As we all know, the endoscopic anatomy in different parts of the ureter. So coming to the physiological narrowing of the ureter, the classic concept is 3 narrowings at PUJ, the iliac vessel crossover, and VUJ. Origin of this concept was attributed to the first edition Campbell Theurology in 1956. Right from that time till now, this same picture has been projected. So vesico-ureteric junction, which is the narrowest portion, it's only 3 to 4 mm and often requires dilatation for ureteroscope and access sheath. The iliac vessel crossing at pelvic rim, the ureter passes anterior to the iliac vessels. And there is a Lushka law. At the right, the ureter crosses 5 centimeters below the iliac bifurcation, whereas in the hip, it crosses 1.5 centimeters above. And in the iliac crossing, the narrowing is not due to intrinsic effect, it is due to extrinsic compression by the iliac artery. So hence, tone impaction and endoscopic gauge zone at the iliac crossing site. Then we know the uretropelvic junction also is a important site of stone infection of importance while doing ureteroscopy. Then there is a notion of crossing point anatomy. So with the new age CT and 3D reformatting, instead of 3 sites of ureteric narrowing, now the recent literature has spoken about 2 sites of main sites of physiological narrowing, the upper ureter and VUJ. Why? Because in the proximal ureter, the ureter is when it comes out of the kidney, it is freely mobile, and then it is fixed on the anteromedial aspect by the psoas muscle. And as at this point, ureter is crossed ventrally by the gonadal vessel, which is the crossing point. So hence, it is the most common site of urinary stone infection per ureter. So what are the endoscopic implications of this ureteric anatomy? When advancing a semi-rigid ureteroscope or ureteral access sheath, resistance at this level should be handled with caution. Never force the instruments. Safe practices, if resistance is felt, avoid forceful advancement and consider driver manipulation, dilatation, or use a flexible scope instead of the rigid scope. Then there are ureteral kinking, which affects the endoscopy axis during RIRS and retrograde ureteroscopy. So radiologically, upper ureter kinks can be divided into 3 grades. Grade 1, where there is no or mild kinking. Grade 2, where there is moderate kinking, and which contains a horizontal portion also. And grade 3, which is a severe kinking containing a retrograde portion. Grade 2 and 3 is considered as a significant kinking. The percentages are mentioned. It is more common on left side. So what is a Merz maneuver? So in order to decrease the kinking and allow the scope access, the surgeon medially presses the upper ureter cephalad and medially with a pressure with a closed fist on the flank. So this can straighten the kinked ureter and thereby the access will be more possible. So coming to the arterial supply of the ureter, as seen in the diagram, the upper part of the ureter is supplied mainly by the renal artery. The middle part is from the abdominal aorta, the gonadal arteries, and the common iliac arteries. And the lower part of in the pelvis, the ureter is supplied by internal iliac arteries, superior and inferior vesical arteries, and uterine artery in the femur. The pelvic ureter has the richest supply, unlike the abdominal portion, which has the poorest arterial supply.
Dr. Kiran, please wind up in a minute. In a minute, please.
Yeah. Okay. So these are the sites of endoscopic incision for endoureterotomy according to the vessel positions. So then there is the PCS anatomy, first given by Sampaio, which is cumbersome to be used. So now most people are using Takazawa classification given by a Japanese scientist. A simple classification where the type 1 is the pelvis forms a true pelvis that is not bifurcated, and type 2 is the pelvis is bifurcated into upper and lower patches. The type 2, the stone free rates are less. So there's a study from Japan where they've shown that in the type 2, the stone free rates are less and the retrograde axis is also depicted. So coming last to the urinary tract angles, white matters, instrument reach and maneuverability, and in case of lower bone stones. So key parameters are first is infundibular pelvic angle, the angle between the long axis of lower pore infundibulum and the renal pelvis. So when the angle is wider, then there is easier access of ureter scoop. Then there is the infundibular width, the narrowest portion along the axis of the lower infundibular. If it is narrow, like less than 5 mm, it is unfavorable and restricts the passage of scoop and basket. Then there is the infundibular length, which is the distance from the most distal part of the calyx to the midpoint of lower lip of renal pelvis. This length. So if it is more than 3 centimeters, it is unfavorable. Then there is a pelvic calyc's height, the distance between lower lip of renal pelvis and the bottommost lowermost calyx. So what is the bottom line for RIRS planning? The best predictors of success is the IPA angle, infundibular pelvic angle, more than 70 to 90 degrees, and infundibular length less than 3 centimeters. Risk factors of failure are IPA less than 45, infundibular length more than 3 centimeters, large stone size, and the lower pole location. So I conclude by saying that you have to know your anatomy, patient's anatomy, the ureteric anatomy, your armamentarium, in order for a safe RIRS. Thank you.
Thank you, Dr. Kiran. I mean, that was an elaborate mention about various aspects of anatomy in RIRS. Any surgical procedure, there is no smooth sailing unless you understand the anatomy well, and it seems good with even with the endoscopic procedures. So highlighted on all the aspects. Is there any embryological aspect that you would want to highlight, especially when there are renal anomalies that would be picked up, especially when you do a cystoscopy itself initially? Is there anything that you would like to highlight on that one particular aspect?
Yeah, it's actually it was a different topic as given for congenital anomalies for RIRS, so that's
Fine.
why I didn't.
Fine.
I thought
Okay.
I'll stick to the anatomy
Sir,
part.
Like to give the comments from the experts, Chandramohan sir and Kandap sir. Any comments?
Kandap sir, what are the important anatomical things quickly you like to see? Which case you feel that RIRS is not safe apart from the tight ureter?
Okay, so first of all, Chandramohan, thank you very much for giving me opportunity to connect to the ASU and the many people in the country who are on the line at this moment. So thank you to the panelists and the moderators and the presenters. Now, I think he has covered beautifully the anatomical aspect. The one thing which probably we need to emphasize that regarding the ureteric orifice, as he said that the ureteric orifice is stretched when with the full bladder. So we always insist that the bladder has to be empty before you take the patient for RIRS, so that your entry into the ureteric orifice becomes easy. Second important point is that if you see the course of the ureteric lumen, from the ureteric orifice on the right side, the lumen is between the 12 o'clock and the 3 o'clock position. And on the left side, it is between 9 o'clock and 12 o'clock position. So when you are inserting a guide wire, be careful that your guide wire should go in that direction. Otherwise, from the beginning only, sometimes in a tight ureter or a small narrow opening, sometimes you can perforate the ureter with the guide wire also. And some people are, just to save money, some people are using even a zebra guide wire. So I think one has to be extremely careful about this anatomical, because we are discussing anatomy in this. So this is very, very important. And as Dr. Chandramohan has said that what are the difficult cases? One is a very tight ureter, bad ureteric orifice, and the infundibular pelvic angle, and especially the ureter in the anatomically abnormal kidney. These are the difficult cases. Your case selection has to be very proper. Don't go for a very large stone when you are initiating your RIRS program. So that is very important, Chandra.
Okay, sir. Over to Deepak. Already I have introduced Dr. Deepak. He also is presenting the talk apart from moderation. Over to you, Deepak.
Thank you, sir. Thank you. I'll take over to the second talk, and I'll be presenting the same. I'll try and
Intrarenal pressure
share
during
my slides.
RIRS.
Yes. So I hope you can see my slides.
Yes.
Yeah. Yeah. Good evening, everyone. And I'll be talking about intrarenal pressure in RIRS. I think it's one of those parameters that are very important for us to understand, especially in these days of RIRS, where we are pretty much advanced. I must say that we have moved a long way as far as doing RIRS surgeries are concerned in this era. Thanks to I always mention this introduction in all my presentations, that considering the advances in endourological technologies that we are happening these days, then the fiber optics and the scopes with brilliant vision that we have, and the lasers that are advancing on everyday basis, we have been pushing our boundaries to do RIRS, especially for the larger stones and complex stones. What happens and what is happening in this process is that the importance for intrarenal pressure and intrarenal temperature has been linked to the outcomes in terms of both complications as well as in terms of long-term effects. So now the new devices which has an ability to measure this IRP and IRT have been introduced into the market, and we should understand them very well before we go ahead and do RIRS. What are the things that you need to watch out, especially in procedures like this, are the four parameters like intrarenal pressure, intrarenal temperature, irrigation, and suction. There's been a beautiful article which has been published of late, which is called as quadrifecta during retrograde intrarenal surgery. Now watch these four parameters that are called as quadrifecta, are nothing but suction, irrigation, intrarenal temperature, and intrarenal pressure. All these parameters individually have their own role to play in a smooth sailing RIRS in terms of efficacy and also in terms of potential complications that might happen as you go by in your surgeries. Now, what are the factors that you need to remember and that will affect the intrarenal pressure? One, the irrigation flow per se, which is actually dependent on the type of the irrigation that you want to choose and the rate at which the irrigation is going to flow. Two, ureteral access sheath, both in the size and the type of access sheath you're going to choose. The working channel, whether it is free or is it occupied with any of the accessories that you're using, or also the size of the working channel in the scope. Excuse me. No ureteral access sheath, does it raise in intrarenal pressure or is it the same? We will discuss that in a slide or two as we go by. And the flexible uteroscope size per se, they're going smaller and smaller day by day. And I think that has been a happy happening for all of us because the sizes have gone down to 6.3, 6.1. So that's a very welcoming sign for all the endourologists. And another important parameters which we have been discussing of late in all our academic journals is the RESD, the ratio endoscope sheath ratio, which is the parameter for us to assess the safety parameters. Now, if I have to talk about irrigation and pressure, these are the few numbers that we all remember from the day we start doing our RIRS. What is the normal intrarenal pressure that we are all looking at? That is around 20 centimeters of water. For this to be achieved, where should be your saline? Maybe around 60 centimeters of water, that will give you 7 to 8 ml. So remember, 6 to 8 ml per minute will keep your intrarenal pressure at a very safe zone. The moment it starts increasing, that is 27 to 40, you'll start seeing a pilotubular reflex. Further ahead, you'll see a pilovenous reflex. And then eventually, if it hits around 80 to 100 centimeters of water, the pharyngeal rupture is inevitable. You don't want the cases to be going towards that direction, and it can be a serious implication for all our patients. Now, what are the implications that we're talking about as and when these physiological happenings happen because of the raised intrarenal pressure? The pilovenous backflow, as and when it is happening, what is it that is happening dynamically in the patient? There is an excessive fluid absorption. There is fluid overload that you can see in the patients, which will eventually result in an electrolyte imbalance. And of course, a cardiovascular instability, especially with the patients which have some comorbid conditions, elderly people, those with cardiovascular issues. You should be very careful when these things are happening. And the most common and most worrisome for all of us are the infectious complications. Raised intrarenal pressure results in infectious complications is a very straightforward thing. All of us know it could be from a simple urinary tract infections following surgeries to an SIRS kind of a syndrome for the patient that is happening as and when the surgery is happening, which will land up in a urosepsis. High intrarenal pressure of more than 204, that is around that level, will result in pathological changes which are irreversible kidney damage. I'll show you an article why this is and what happens actually when such high pressures are happening. A pharyngeal rupture will result in a perirenal pseudocyst, a retroperitoneal edema, and a perinephric abscesses also as a long-term complications. And the most dreaded for all of us, bleeding in RIRS, it can happen because of a papillary damage, a subcapsular hematoma, and even a perirenal bleeding. We all have, I'm sure the seniors here would have all seen this. This is a few pictures I can quote and show here where post immediate RIRS with high pressures results in a perirenal, hematoma, and there are procedures where we had to drain the hematoma also, as well, to cut down on the page effect on the kidney. We don't want to see our kidneys like that happening. And now coming to the evidence that we have about intrarenal temperature, pressure, and suction during intrarenal surgery, there is only one thing that all these papers say. Powerful irrigation during retrograde intrarenal surgery should be cautiously applied because it raises all possible complicational prospects, and a manual pump irrigation especially causes an extremely high IRP, which will possibly lead to infectious complications and sepsis. Now, if you carefully watch this particular table in this paper, all I want you to see is a couple of parameters, that is about IRP, which is very high, especially in pressure bag scenario and in hand pumps. It can reach as high as 260, where we are looking at above anything above 200 in dreadful complications. And another paper which is actually commenting about the other parameter which I mentioned about having accessories in the working channel. The moment you have any accessory in your working channel, if you can closely look at the numbers, either it is a basket or a laser fiber, in a smaller access sheath, the pressure tends to be much, much higher when you compare to a larger access sheath. So that is the important parameters which can give us an indication on saying that the larger the access sheath, the better and the more improved the irrigation will maintaining a significantly low intrarenal pressure. And that is the one parameter that we all should understand. Coming to high pressures in endoscopic irrigation and the impact on renal histology, this is a very, very important and interesting paper where you say that as the pressure in the kidney is increasing, and if there is no access sheath, the pressures are immense and it causes some irreversible damage through the histology of the kidney. Very, very clearly seen. Without sheath, even at 50 millimeters, it goes to 30, whereas with sheath, it is hardly at 1.2. And this is a study which has shown us what happens even in histologically to see all these changes with the tubular the tubules within the kidney get calcified, and also the bleeding results in the death of the tissue. Coming to another parameter and study that they have studied in vitro, where they say that optimizing the efficacy in RIRS in terms of the RESD ratio, which I was saying, is one of the most important parameters, that the smaller the RESD ratio, it leads to a good aspiration as well as keeps the pressure very low. And this is another interesting paper where is a meta-analysis kind of a picture which is studying on the utility of the instruments and the future directions intrarenal pressure. Very interesting study by the Global Research Intrarenal Pressure Collaborative Group by Steffi. She is the author in this, but the current clinical studies have ascertained that the increase anything above 40 is dangerous. We all know that. But unfortunately, there are no standardized values as well as to predefine the safe threshold levels in a practice as of now. So for you to give you an outline on what are the IRP monitoring devices which we have in the market today, we should understand this because this is the future and you should know what is available in the market. I'll stick to the non-invasive retrograde intrarenal surgery parameters. The IRP monitoring can be done in terms of wires, scopes, sheaths, systems, or stents. There is a rapid progress happening in the technology as we are speaking. I'll not elaborate on each of these. This is a brilliant paper. All of you should go through to understand what is it that is available. And we do have some in very own Indian companies like Biorad does some scopes called as Sensei, which has got a pressure sensor in it. It also produces system-based pressure sensors where you see it on the monitor like this. We have, I think few of you have already been using it or you're using it, which will give you a pressure monitoring parameters on the screen. But what we should understand as clinicians is how do we react as a surgeon when you see such parameters? Do you do something immediately so that the pressure comes down? Yes, you should, but I think it will take some time for us to understand watching these parameters and equally responding as we are operating. This is another option even from the Cleopatra guys. They have the same thing. All the companies are going to come out with this. So if you have to put everything in a nutshell, how do you manage an IRP? Make sure the scope, smaller the better. Bladder, keep it empty. System, if it is obstructed, make sure you pre-stent it or put a PCN. Your RESD, which I was saying to say, should be around 0.75. It is difficult to understand the numbers. Simpler way is saying smaller scope, bigger access sheath. Make sure the ratio is good so that the irrigation happens well. Instrument presence, you should always make sure that you increase the flow rate. Patient position, supine is the best. Stone location, try and relocate and keep it in a favorable position so you don't overdo the irrigation component. So I put it in a nutshell. as far as the risks and solutions are concerned, the high pressure will result in renal damage, infections, and bleeding. And high pressure also means it is because of increased flow, no use of access sheaths, and empty working channel results in a large flow of saline. So take home message, I would say, make sure keep the IRP above around 40 millimeters. Anything above that can result in infections. Flow rate around 7 to 8 ml or 10 ml is more than enough. Avoid hand pumps or pressure bags for irrigation, which is deadly. Prefer ureteric access sheaths, or if you're going sheathless, your scopes have to be small. That is another topic for another day for discussion. I'm sure that is a controversial one. And keep your adequate, the scope size and the access sheath diameter at a perfect ratio so that there is adequate backflow. Adapt to these IRP monitoring devices. We cannot run away from this. That is the future. As of now, there is nothing standardized about it, but I'm sure we're going to get very high quality comparative studies very, very soon about this. Thanks a lot. Thank you.
Thank you, Deepak. Nice presentation. Quick comment, one comment by Dr. Kandar Parikh, sir. I ask you a question, sir, to both. Do you think that both of you, do you think practical monitoring of the pressure on the skin and surgery stop patient go down is going to come in the future because the already scopes is there? I was enthusiastic for one case. After that, I said that there is no need. I will understand. Both of you, quick comment.
I think it's a kind of a muscle memory and how you react to these changes when you see these pressures. I made the very same comment. It's not going to be easy to start with. I guess in due course, you will realize that, okay, fine, your irrigation has to be at a particular height, particular kind of irrigation is giving you low pressure. Maybe you'll do the trial and error with all the devices around you and you will come to a conclusion, okay, if I do a surgery at this, in this format, the pressure will remain low. Real-time reaction, maybe it's challenging. Kandarp sir, maybe you can comment on this.
Dr. Deepak, is there any system?
Yeah,
sorry,
sir, tell me. Question, ask the question, sir. Others, please unmute.
Yeah, now am I audible? Hello? Am I audible?
Yes, sir, you're audible. Please go ahead, sir. Please go ahead.
Yeah. Is there any sensor system in the horizon where it senses the pressure and automatically cuts off the irrigation and resumes the irrigation automatically when the pressure comes down? Pressure or temperature system. Is there anything in the horizon?
We already do have, sir, one from the ZSR. It is called as iMimmer. It has an AI-based solutions where it picks up the pressure within the pelvic ileal system and it does slow down the irrigation rate and cut short. It's all happening, very recent happening, sir, in the last 1 year. But I think we are still learning how these systems work. But we do have one in the system, in the market already. Yes.
Yes, Chandramohan. First of all, Deepak has covered it beautifully.
Yes,
excellent. Now, regarding your question that whether we can monitor and operate simultaneously or not, believe it or not, this is going to be the future, and probably all of us will be monitoring while operating. And when more and more youngsters are picking up the RIRS in their routine practice, I think it will be imperative to understand the importance of intrarenal pressure as well as the temperature. Now, with the experience, experience you have, you know that what doing. And while you are performing the procedure, your assistant also plays a significant role irrigating the system with the pressure. Because though it is said that the gravity irrigation is the best thing, most of the people are not using that gravity irrigation. That is one. And second important thing is that if you are using the plastic bottle for irrigating the fluid, once the fluid gets over, I think probably it will be very difficult to say that the fluid is going at this pressure and this amount of the fluid is going per minute. So it is extremely difficult. So that's why we need a monitoring system. But once you get an experience, adequate experience, I think probably you may not be needing it because you exactly know that what is happening. Yeah.
Thank you. Next speaker, Deepak, please. We
Yes,
should, we have crossed the magic figure of 200. That's a large number. Let us keep the last speaker also into consideration. So
Fantastic,
we will
sir.
try to be in time. Thank you.
We'll try and stick on to the time. So we'll move on to the third topic, that is armamentarium used in RIRS by Dr. Bhargav Vardhan Reddy from Nandyal. He is the managing director and consultant urologist of Nandyal Kidney Center. Senior experienced urologist from the city of Nandyal. I'll hand over the stage to him to speak about armamentarium used for RIRS. Over to you, Dr. Bhargav.
Yeah, thank you, Deepak. Sir, thank you, Urology Association of South Zone, for giving me this opportunity to present a talk on armamentarium used in RIRS. So, after the invention of flexible ureteroscopy and laser lithotripsy, the most of the indications of 10 to 20 mm stones are shifted from ESWL and PCNL to the laser RIRS. So last 20 years, RIRS got popularized in India due to advancement in technology. In 2007, when Chandramohan sir started RIRS in Hyderabad, it is a new technology, but not a nowadays. Even in peripheries, we are doing RIRS nowadays. For even 2 to 3 centimeter stones, we are doing nowadays. So you need to have few special instruments and disposables to perform a safe and effective RIRS. So there is a few histological evaluation of RIRS. The first flexible scope invented in 1964. After that, they clinically applied in 1970. Between 91 and 2001, there are major advancements in the technology of flexible ureteroscope, in the miniaturization of the scope, and the research on the deflection of the scope. In modern era, the digital scopes came into the market, from the fiber optics to the digital scopes. The core components of the RIRS armamentarium are the flexible ureteroscopes and the laser lithotripsy. With the frequent and expanded use of flexible ureteroscopy, other ancillary instruments are developed in order to facilitate this technique, such as ureteric access sheath. These are the things you required to start the RIRS procedure. The guide wires, ureteric access sheaths, even 8 French ureteroscope is also needed to see the system. And these are the guide wires. The various commercial available guide wires available in the market. Commonly used guide wires are Boston Scientific, Thermo, Cook, and Indian or Blue Nim guide wires. What is the ideal guide wire? The ideal guide wire requires a combination of flexible tip and the hydrophilicity, shaft stiffness, and the kink resistance. The hydrophilicity of the guide wire helps in the smooth tracking of the guide wire and to navigate the complex anatomies across the any ureteric kinks and complex anatomies in the system. So there is a hydrophobic guide wire is also there. These are called as stiff guide wires. Usually, what in my practice, what I do is I do scope with a 6 French ureteroscope initially with the hydrophilic guide wire. After that, I change the guide wire with the hydrophobic guide wire, that is stiff guide wire, because it enables and it easily helps in the passage of the ureteric access through the ureteric orifice and across the iliac vessels also, because it avoids buckling of the guide wire in the bladder. So there are biwares also there. Biwares means both ends have flexible tip. It helps to backload of the guide wire through the ureteroscope. The next comes ureteric access sheaths. So most of them we are using ureteric access sheath nowadays. So what is the main advantage of ureteric access sheath is, as Deepak said, to reduce the intrarenal pressure by not exceeding the 30-40 intrarenal pressure. So other advantages of ureteric access sheath are they reduce the stress on the tip of the ureteroscope during the advancement through the ureteric orifice, and they allowed the repeat insertion and withdrawal of the scope while removing of the stones through the track. And they also prevent the damage of the working channel by backloading of the guide wire. Without the ureteric access sheath, if you do RIRS, if you have to backload the guide wire through the working channel, there is a heavy chances of damage to the working channel. So what is the ideal ureteric access diameter? It depends on the size of the your flexible ureteroscope. The ideal ureteric access sheath length depends on the sex of the patient, male or female, and the stature of the patient. So these are the access sheath available in the market. The most commonly used are the 9.5, 11.5. And in females, we use 35 centimeter, and in males, depends on the stature, 45 and 55 centimeters. These are the commercially available ureteric access sheath in the market. Commonly used Indian varieties are Indovasive and Blue Nim ones. The recent addition of the one of the addition with aortic access sheath is having a suction capability that is called as fans. They have a suction port by the side, and they increase the stone free rates by 75%, 97%. So modified access sheath for continuous flow ureteroscopy, the paper first published in 2016, and later on the utility of flexible and navigable suction access sheath, that is called fans, undergoing same session bilateral ureteroscopy. This was published in 2005. So what are the disadvantages of ureteral access sheath? The major complication of ureteral access sheath is the uretic wall injury, that is uretic stricture. So most of them are mild only and transient, and they are possible with improper selection of the size. These are the grading of the uretic access sheath injuries, and this is my own case. This is my own case. After using more than 10 cases, this is struck in the ureter. Luckily, I could able to remove this under the CM guidance. This is the fans sheath. So don't use the uretic access sheath if the coat is damaged and if the hydrophilicity is not proper. So as Deepak rightly said, this is the scope and sheath ratio. In pictorial diagram, see this 7.5 scope in the 12 French sheath. So the diameter, if it is less than 0.75, so it will reduce the renal pelvic pressure, it maintains the renal pelvic pressure around 30. So a larger diameter of uretic access sheath is better. And now the another accessory is the stone baskets. Flexible ureteroscopy baskets are used for safe retrieval and manipulation of the stones within the urinary tract. This is one of the videos showing a relocation of the lower pole stone into the upper pole for the easy fragmentation of the stone and avoid stress on the scope. So these are the available various baskets available in the market. And this one is the also called as Entrap. This is triflex design. Holds the advantage of this basket is it holds stone like a basket and it releases like a grasper. These are the various baskets available in the market. So another material used in our Armamentarium is infusion pumps. What are the advantages of infusion pumps? To have a clear vision and to have reduced renal pelvic pressure around 30, they helps us in the surgery. Though most of the surgeons don't use CM while passing the aortic access sheath. In my personal experience, CM is must while passing aortic access sheath to prevent buckling of the aortic access sheath in the bladder and to prevent injury, inadvertent perforation of the ureter at the iliac vessel levels and at the pelvic level. So CM is must while passing aortic access sheath. There, the flexible ureteroscope is also called as surgeon eye inside the kidney. They evolved from the basic fiber optic to the digital platforms, primarily categorized by optical technology, fiber optic and digital, and reusability, that is reusable or single use. Fiber optic, fiber optic means uses bundle of optical fibers to transmit the image. And nowadays we are using digital scopes, which are having superior image quality. This is called a tiny CMOS or CCD chip at the tip of the scope. They directly transfer image to the monitor without having this granular appearance, which was in the fiber optic scope. So reusable scopes are high cost, requires meticulous cleaning and sterilization, and they are prone to damage over the time. Single scopes are the recent advantage. They are light in weight. These scopes are sterile and ready for use. These are the various scopes available in the market. And there are the types of the scopes depends on the mechanism of the tip flexion. This is called intuitive or counterintuitive. This is called intuitive. When you down the lever and it will come down.
Bhargav, unmute. Bhargav, unmute.
Unmute. Yes, yeah. Yes, sir. Yes, sir.
Thank you. Thank you.
Dr. Bhargav, please unmute and please wind up in a minute. We are closing on time.
Yes, yes. This is the counterintuitive scope. When you press the lever down, it will come upwards. So there are the different types of the scopes depending on the laser fiber exit also. When the fiber exit in the 3 o'clock position, it performs, it is better for the right posterior and left anterior and left lateral surfaces. Similarly, there is the 9 o'clock position exit scopes are also there. There is an advantage, there is recent additions of the flexible ureter scope. There is smaller size of scopes available. 6.3 scope recently added in our Armamentarium. And another advantage is the suction flexible ureteroscopy. And the recent advances are the pressure monitoring scopes. And the important thing in the we have to have is the lasers. The two most commonly used lasers are Holme mag laser and TFL laser. There are certain advantages for Holme mag laser, and the recent addition is the TFL laser. The advantage of TFL laser is the high power, and they are lighter and they require lower energy settings, and they have excellent popcorn ability. But the only problem is their vision will be compromised within minutes. So these are the difference between the Holme mag and TFL laser. This is the energy from the Holme mag laser, and this is the TFL laser. And the robotic platforms also coming into the picture. The ergonomic surgeon consoles, precise manipulation capabilities, and reduced surgeon fatigues are very important. And after the increased popularity of the RIRS, what is the most common problem we are getting now is the urosepsis. So choosing the correct sterilization method is very important to prevent urosepsis in case of RIRS. So the most commonly used the sterilization method is ETO. So it can effectively penetrate the complex instrument channels and lumens, ensuring complete sterilization while preserving instrument functionality and longevity. So what are the future directions in development of the flexible RIRS? This ongoing miniaturization is there, and artificial intelligence integration and robotic refinements, and the digital imaging technology is improving. And flexible ureteroscopy has certainly progressed to the forefront of the endurance armamentarium in the treatment of complex cases of renal stones. Having right instrument in the right situation will help to facilitate positive operative outcomes. Thank you.
Thank you, Dr. Bhargav. Thank you. That was Armamentarium in RIRS has always been very extensive, and there's a lot of things to focus, and you have beautifully covered most of the topics. Thanks a lot for that. Any quick comment from Kandap sir or Chandramohan sir? So that we'll move on to the next.
We'll move on.
Okay, sir. Thank you. I'll pass on the buck to Dr. Manohar. Kindly take over and conduct the next three talks, please. Thank you.
Thank you, ASU, and thank you, Chandramohan sir, for giving me an opportunity to moderate the session. So I welcome Dr. Narendra. Narendra is an associate professor of urology in the Institute of Nephrology and Mysore branch. So he'll be covering on the principles of the movement on RIRS. Narendra, you can start.
Yeah. Is it audible?
Yes.
Sir, good evening, everyone. Dear seniors and colleagues and my dear friends, thanks for the opportunity from the ASU Council. I try to finish as early as possible because the most important topic what I have given is the flexible ureteroscope principles and movements. So I have no conflicts of interest because various types of scope is involved in this subject. So there are a few principles which have been seen everywhere. Most commonly, these are minimal invasive access. The second is the visualization. The third is working channel. The procedure of RIRS is the scope is inserted through natural pathways like urethra, bladder, and ureters, because it termed as a minimal invasive because you can do up to the 2 centimeter of the stones without any external cuts. So visualization has been, the previous speaker has been said few things about what is fiber optic bundles. I don't want to go through details.
Your slides are moving. Just check once. Your slides are your disclosure. No, we are not able to. We have stuck at the disclosures. Yes.
Yeah, now it start. Yeah, you continue.
Now, yes.
Now it is moving. Yeah. Okay.
Yes, continue.
Now the principal one, the slide is moving.
Yes. You can continue.
Yeah. Okay, sir. It's a minimal invasive access. Second is visualization, the fiber optic bundles and a digital chip on tip. I think the screen is okay now, sir.
Yes, you can continue.
Yeah. Okay. So the traditional fiber optic scopes, these scopes are transmit images from the tip to the eyepiece using the bundle of thousands of tiny fragile optical glass fibers. The light is typically supplied by the external light source and the image is captured by the camera head attached to the eyepiece. This results in a honeycomb or grainy image due to spaces in between the individual fibers, which is abolished by the chip-on-tip scopes. In a modern scopes, the digital scopes have a tiny high-resolution digital image sensors, has been explained earlier, CCD or CMOS. Instead of a fiber optic bundle, a tiny high-definition digital sensor is placed at the very end of the scope. The image is captured by this sensor, converted into a digital signal, which is then transmitted up to the wire to the video processor and the monitor. This is very important. The illumination is often provided in integrated LED lights at the tip. We can able to see this.
Yes.
We can see the metal tip and a probe with a small bevel design. These are the various scopes we can able to see. In the left-hand side, we can see the camera with an integrated LED source unit, with an front LED source unit, high sensor CMOS, and we can able to see the 160 pixels high resolution image, a dual image. This is one of the principles is chip on tip.
Hello.
The slides are not moving.
Okay, one second.
Yeah.
You can continue.
Oh, just a moment, sir.
Narendra?
So, audible?
Yeah, you're audible. Continue.
I think your internet connectivity is not good.
No, sir, it is clear here. Okay.
Chalo, proceed.
Yeah.
Hello.
Hello.
You have sharing? No, you can share.
Your audio is not there, Narendra.
Narendra, audio is not, we can't hear you.
Now, is it audible now?
Yeah.
Yeah, you are audible. You can continue.
Yeah, okay. Sir, what slide you are visualizing, sir, there?
We are seeing a simple fluid dynamic model of we can move on, continue.
Okay.
No, you have to share the screen. You're out of the screen.
I'll share, sir. Give me, sir. Sorry. Very sorry for that.
No problem, sir. Please. Meanwhile, sir, quick questions are, will you dilate the ureter, Dr. Kandar Parikh, sir, in a non-stented ureter if it is tight? Will you dilate the ureter, sir?
No.
Kandar Parikh, sir?
Okay, hi, yes, Chandramohan, I heard you.
Generally, we don't dilate the ureters. Okay.
Stent it and come out.
Stent it has come out. Correct, sir.
Narendra, you can start.
Yeah, sir. I think the screen is on now.
You can go to Flexi URS. You're on slide 13, I think.
Chip on tip is over.
Chip on tip is over. Okay.
Continue. Your slides are not moving.
Yeah.
Okay.
Yes,
so
sir.
there is some
Sir.
technical
Yes, sir.
issue.
Now I am okay, please, sir.
Can we share the PPT from our side so that you speak?
Yeah, that will be better, sir. That's good.
Yeah, just we are stop sharing. Rajendra, you share the screen. We are sharing from our side. You stop the double voice. Don't see the webinar in two phones. Just
Yes, sir.
speak. if you cannot speak, then we will switch over to next speaker. You are talking about the flexible scope movements up to the chip on tip scope. We are there. Rajendra, you are sharing the screen.
Yes.
Please
share, sir.
Yeah, we are sharing. We will take the control.
I think we'll move on to 13.
Yeah, we are moving.
Yes, sir.
Yes, from here you can speak.
Yes, sir. Yes, sir. Okay.
Go ahead, speak. You are not speaking.
Yes, sir. So the third principle, what we have seen is a working channel, the critical pathway for dual functionally, and which irrigations allows for a flow of sterile saline to clear the field of view. These working channel provides a channel for various tools. We can able to pass on now we have a dual working channel also. We can have a working channel for laser, working channel for irrigation. Next slide, please.
Yes.
So you can also see the upper end of the working channels, which have been designed for different scopes. They are all custom made also. Next slide, please. So the most important thing is we have to understand the length of the ureter scope can vary depending on the specific model and the manufacturer. The working length is in the range of 65 to 68 centimeters. Some sources provide more specific lengths for different models. For example, we can have a 67 centimeters in Olympus, in a Storch for 68.6 and a Wolf for 68 centimeters. It is important to note that the total length of the ureter scope, including the handle and the cable, be much longer than 100 centimeters. The shaft length or working length is a key for instrument for clinical use. In this diagram, we can able to see the semi-rigid scopes working length when compared to the both the digital scopes. Next slide. So this is an calculation for the length of the scopes. The common size of the outer range of the sheath is 6 French to 9.9 French. The distal tip of the very end of the scope is often tapered to the smaller diameter in edge to passage, ranging from 5.3 to 8.7 French. The recent advancements has led to the development of mini or smaller diameter scopes with small models being the small as the 6.3. These are particularly useful in cases of challenging anatomy of the pediatric procedures. Next slide. This small diameter limits the size for a quantity of the devices that can fit through the working channel, as well as the size of the object such as stone debris can be extracted, while the device remains within the working channel, like laser fiber or a use of kidney fragment stones. Dual channel flexible ureteroscopes are also available in the market, but they have their own issues in maneuverability and provide less visibility because of additional space in the ureteroscope shaft to be dedicated to the second channel. Furthermore, dual channel ureteroscopes are costly to obtain and maintain. Next slide. So this is a simple model to explain to maintain the UPJ. So the parking of the ureteral access sheath is just below the UPJ. The urosepsis after ureteroscope occurs due to a pilovenous backflow in the urine and the harbored in the stone that is fragmented. Next slide. So what are the most important is basic movements of the ureter, flex ureteroscope to navigate the kidney. See, the journey starts from the ureteric orifice to the UPJ and to all the calyces, from the superior calyx, middle calyx, and the lower calyx. It starts from the active deflection, rotation, and advanced movement of the passive bending. A skilled surgeon can navigate the complex three-dimensional anatomy of the upper tract to diagnose and treat the wide range of conditions. Next slide. So ureter is not a straight object, and it is not a small. It is small in diameter. We can able to pass through the pelvis, and also we can access across the psoas, and we can able to reach the three natural constrictions of the ureter. Next slide. So this picture represents the rotation of the shaft position to the working channel at 12 o'clock when it is eccentrically placed, which prevents the lens from catching to the orifice and also the distal ureters causing telescoping. Next. These are the basic movements of the flex uroscope. This is most important. There are six basic movements we have to try to understand. One is deflection. The deflection again classified into active deflection and a passive deflection. The deflection in the active can be primary deflection active primary, deflection active secondary, and also rotatory movements. We have micro rotation and macro rotation, which has suits the conditions of the ureteric orifice. And in and out movement are also called as push movement or advanced movement, which is most important to reach the stone with access to the calyx to fire the laser. And this pronation and supination, it is depends upon the right and left kidney to reach all the calyces. The role of the surgeon hands is very important, both dominant and non-dominant hand. These are also access. These are complete movements, helps to do advancement to the pelvic calyceal system. These are again pictorial representation of the deflection, rotation, in and out movement, pronation and supination, and the role of the surgeon hands. These all the movements give us to proper access and stability towards the access to the PCS. Next slide. See, this pictorial diagram shows about the representation of 90-degree flexion, 270-degree, 272-degree, and also you can able to see across the 300 degrees. These are the calculation how exactly the movements of the tip of the scopes. See, there is a 5 to 10 centimeter of the distal. It is a maneuverable scope which helps for the directions from 90-degree to 120-degree or 270, 272 degrees. Next slide, please. See, the bending section, articular section is very
1 minute
important.
left behind,
Next
sir,
slide.
please. 1 minute.
Last minute, Narendra.
Speak, sir, speak.
Yeah. The deflection portion is typically in the range of 5 to 10 centimeters. The bending portion is very important. We have to try to understand this bending portion is to access all the pelvic calyceal system. So while the total working length of the flexible scope is typically around 65 to 68 centimeters, the length of the bending section itself will be much shorter. Based on the manufacturer specification, the technical documentation, the length of the above deflection portion is typically in the range of 5 to 10 centimeters. Next slide, please. So deflection mechanism, I told you there's active deflection, primary and secondary and passive. Next slide. In active deflection, operated via lever, which has been given, it is up and down. This is most important, is an intuitive movement. The range of motion expressed as x and y degree, even it is given up to the level of 270 degree up, 270 degree down, which enables the bending in two opposite directions in a single plane, and it is bidirectional, crucial for reaching the lateral and lower regions of the infundibula. Next slide. Deflection active secondary. So there is a separate additional bending mechanism located more proximally on the shaft. Usually a few centimeters low down. We can able to see there is an active deflection, which is a secondary. We have a passive deflection, which is the curvature which is bends at the pelvis. The moment you pass through the UPJ, you are still advancing the scope. There is a passive deflection. Whereas when you want to reach the lower calyx, you need to do the deflection, which is active. Next slide.
Sir, you have to be quick, sir.
You can you
slide.
give messages?
Yeah.
Maximum. Yeah.
Next slide, please. So deflection ranges from, we can able to see 270 degree, 275 degree. Next slide. So deflection of flexi is so very important because there is a few factors affecting the deflections, the insertion of the instrument, anatomical variations, and the scope designs and clinical implications. And maintenance of the deflection is it's a learning curve. Next slide, please.
Can you conclude in brief?
Yeah.
Yeah.
So basically, the deflection mechanism, it's an intuitive movement. Comparatively, in reality, the counterintuitive movement is less commonly done, and it is a counterintuitive movement. It is a combination of deflection with a rotatory movement. See, basically,
Sir,
intuitive
please
movement.
conclude, sir.
Next.
Sir,
Okay.
we will conclude, sir.
You can conclude to the last slide.
Finals. Yeah. Rotation, we have micro rotation. We can go ahead. In and out movements with pronation and supination. Okay, the basic principles of conventional and digital scope should be known by the operating surgeon. Learning curve, the initial learning is a simulation, transition learning with a mentored cases, and a mastery by independent practice. These movements you have to understand about linear movements, active deflection, rotation. Thank you. Sorry for the internet issues here. I am extremely sorry.
Dear Kandar Parikh sir, are you online, sir?
Chandramohan sir, you can give expert comment.
Yeah.
Yes, Chandramohan, I am online.
Yeah, sir, quick questions, 2-3 questions which are asked in the internet. Number one is, if the access sheath is more outside like fan sheath, do you need a long flexible scope? Sometimes if you want to go to deep, upper calyx deep, do you require longer scope where scope snugly fits at the end with the...
I'm Chandramohan aware of longer scope, because I prefer that regular ureter sheath, the ureter access sheath should be at the level of the penis. In a male patient, in the female it slightly protrudes out. But as if the access sheath is too much outside, it will hamper the movement. So then, the regular length of the ureter is about 67
That's the answer. That the top to tip of the urethral meatus, if the sheath is there, scope length cannot be increased because scope lengths are fixed. You cannot produce. Sir, do you do any dilatation of the ureter if the ureter is not stented and tight?
So the ureter can be narrow. So first thing is that when I do flexi-ureteroscopy, my first step is to do a semi-rigid ureteroscopy with the 4.5 French ureteroscope. So if I feel that only the ureteric orifice is tight and the rest of the ureter is normal, sometimes I dilate it with the balloon. Now some people dilate it with the Teflon dilator also, but I prefer to do dilate with the balloon. Otherwise, I put a stent and come out. Yeah.
Thank you,
Chandramohan.
I'll move on to the
Chandramohan,
next.
the tip of the access sheath should be just below the PUJ.
Yes, sir. Yes, sir. That's okay.
Okay, I'll call upon Dr. Manasa to speak a topic on accessory use during RIRS. Manasa.
Yes, sir. So, one second. I'm sharing the screen.
Yeah.
One second. Can you see my screen, sir?
No.
We are not seeing.
1 minute, sir. Some issue.
Is it raining in Bangalore and Mysore?
No.
Sir, sorry.
Yeah. Now it is shared.
Now you can see, sir? Yeah.
No, you are sharing the... Okay.
You can, yeah.
Yes.
Yeah. So good evening, everyone. And thank you, Manohar, sir, for the introduction. And thank you, Dr. Chandramohan, sir, for this opportunity, and the ASU Council. So an accessory in any surgery is to assist a surgeon while performing a task to improve a particular maneuver or a step, thus enhancing the outcomes or the surgical safety. So these are the accessories that one needs to have by the side while performing an RIRS. I think most of it is already covered by Dr. Bhargav. When it comes to guide wires, again, it's classified based on the material, whether it's nitinol or the stainless steel guide wires, based on the coating, whether it's hydrophilic or the PTFE, the tip, whether it's flexible. It can be a straight tip, J tip, or an angle tip, and the flexibility can be, the length of the flexibility can vary from 1 centimeter to as high as 15 centimeters. The diameter, we all know, ranges between 0.018 inch and 0.038 inch. And the length is anywhere between 80 and 260, but most commonly what we use is a 150 centimeter. Hydrophilic guide wires, they have a gel-like surface, so they help in navigating any complex anatomy like the Terumo guide wire. But the disadvantage is that they're very slippery. And the hydrophobic guide wires, they have a better tactile feedback and control. They help in maintaining a stable position. They're usually PTFE coated. The common guide wire, as already discussed by Dr. Bhargav, is the Terumo guide wire, what we use, which is a nitinol alloy core with a hydrophilic coating. And it has got tungsten infused polyurethane jacket, which makes it more radio opaque. Another common guide wire that we use in RIRS is a glide wire by the Boston Scientific, and this is coated with a proprietary polymer jacket, basically to minimize the risk of trauma and to reduce the risk of uroendothelial perforation. We also have the high wire with enhanced coating, which is more radio opaque, and the bi wire, which is like 2 guide wires in one, has got flexible tips at both ends, that's straight at one end and an angle tip at the other. So this facilitates instrument exchange or placement, as well as reduces damage to the flexible scope. We can also use the zebra guide wire, which has got a nickel titanium alloy core and a PTFE coating. And this is for better handling in difficult ureters. And an ideal guide wire is one which should have a flexible tip, which should have a stiff shaft, and which should have a hydrophilic coating and should have retention friction as well. With this principle, hybrid guide wires have come into the market, which is more useful in enlarged median lobes or when there is an angle at the VUJ where the axis sheath passage is difficult. The common ones in the market we have is the sensor guide wire and by the Boston Scientific, and the motion guide wire by the Cook. The sensor guide wires, they also have a dual flex configuration with a 10 centimeter flexible proximal end so that there is an easy passage of the flexible ureteroscope. The next accessory is the ureteric catheters, commonly used are the single lumen catheters. They range between 3 and 8 French diameter, 70 centimeters long. One is to inject contrast, we use them most commonly. Second, to drain the PCS. The third is to place the guide wire safely. It comes in various modifications. That is, you have the visual tip, the angle tip, the closed tip. And of importance is the dual lumen catheter. This 2 lumens helps in avoiding multiple passes. That is, we can simultaneously inject a contrast as well as place a guide wire. And it is of a larger size, that is 10 French diameter. So it also acts like a dilator at the VUJ. Then we have the ureteric dilators. I think Dr. Kandap sir has already mentioned that we don't necessarily dilate. In my practice, what we do is we go with a 6 French semi-rigid ureteroscope followed by a visual dilatation with an 8 French semi-rigid rather than using conventional ureteric dilators. However, to mention, we can use sequential dilators which can range between 6 to 16 French, or can use a balloon dilator which has got a length of about 4 to 7 centimeter and can be inflated to a pressure of about 8.5 atmospheric pressure. The ureteral axis sheaths, again, there's always been a debate whether to use it or not. The pros for it is it helps in repeated access to the pelvic ileal system. It lowers the intrarenal pressures, hence improving the visibility, drainage, reducing the risk of infection. It does have its cons. That is, it causes superficial mucosal ureteral wall lesions in the immediate post-operative period, which need not necessarily translate into a ureteric stricture. And it also adds to the cost of the procedure. However, most of us would agree that we use an axis sheath over not using one to keep the IRP low. So a traditional axis sheath has got an inner dilator which tapers smoothly from 6 French, and it ends on a dilator hub which secures it to the funnel of the outer sheath. Now the outer sheath has got an hydrophilic coating. It has got an inner metal coating so that it is kink resistant, and it has got a PTFE coating for a smooth passage of the flexible scope. And it has got a funnel at the end which acts like the handle as well. Now, these are the various ureteric axis sheaths that are available in the market. One can choose whichever they want. And there are various sizes available starting from 9.5 French and going up to 14 French. The minimum length available is 13 centimeters, going up to 55 centimeters. I think most commonly we would use is a 28, 35 or 45 centimeter, depending upon where we want to place the ureteric axis sheath, whether it's to place in the lower ureter, mid ureter, or in the upper ureter. The recent modification is the flexible navigable suction ureteral axis sheath by the fans. It's known to cause shorter operative times, there's lower post-operative complications, and it's got higher stone-free rates. In fact, studies have compared it to mini PCNL and found it has got better, safer outcomes with equal stone-free rates. This has got a flexible, bendable tip, and it comes in various sizes ranging from 9 to 14 French, and it has got a start and a stop button. These are the various irrigation devices. Gravity by far is the best and the safest way to keep the intrarenal pressures low, but most commonly people use a 50 or a 60 cc syringe. You can use a Pathfinder single action pumping system by the Boston Scientific. Then you have the automated systems by the Rocamed and the stores, or the foot operated system by the Teleflex. Coming to baskets, when buying baskets, what to look for is the configuration and the linear opening dynamics, the ability to capture, retain, and disengage, the visibility of the stone during the stone manipulation, and its maneuverability. So the most often we use is the nitinol basket. It could be a flat, round, or a delta wire, and either a front or a side action basket, and most often we use this a tipless one. Why nitinol is because it has got a better shape memory, and it is super elastic, and it's kink resistant. Now, these are the common side action baskets that we use, the N-circle. by the Cook, the zero tip by the and the Segura tip plus by the Boston Scientific. The front actions ones are the Dakota, the Engage, and the Jeeper. The end circle comes for RIRS in sizes of 1.5 and 2.2 with the basket diameters of 1 and 1.8. It is also available in the Delta wire design. The Delta wire has an advantage that it doesn't lose its memory so fast, and it can be used for multiple uses. This is the zero tip nitinol basket by the Boston Scientific. Again, comes in 1.9 and 2.4 French size and has got a cage diameter of 12 mm and 16 mm. The Engage, this is what I use most commonly in my day-to-day practice. It's a front open basket. The advantage of a front open basket as compared to the side open basket is that it catches the fragment easily and it releases it also easily. So it helps in relocation of the stone better than a side action basket, and it has got lesser chance of getting stuck unlike the side action baskets. It comes in two diameters, 8 and 11 mm, and it holds like a basket, releases like a grasper, like I mentioned. So it has got a 50% greater retention strength than traditional graspers. Another commonly used front open basket is a Dakota basket with an open shore handle, which opens like a flower. It comes in 1.9 French size, which is 120 centimeter long. It again opens to two sizes, 8 mm and 11 mm. It can capture stones as less as 1 mm and release stones up to 10 mm in size. And a head-to-head comparison was done between Engage and Dakota. It was found that Dakota was more effective in capturing stones more than 7 mm. And it in fact reaches more deeper and captures smaller fragments. GPO is another basket by the Indovasive. It comes in sizes of 1.7, 1.9, and 2.2. The only disadvantage is that with multiple excursion, it tends to lose its memory faster. The other basket is the Encompass basket. It has got a multi-wire geometry, and it is best when you have to remove multiple small fragments. We also have the Escape basket by the Boston Scientific. It opens to two sizes, 11 and 15 mm, and you can simultaneously pass a laser fiber, and it acts like an effective anti-propulsive device. The smallest one, which I'm aware of, is the Optiflex basket by the Boston Scientific, which has demonstrated a better irrigation flow, and it extends to different sizes of diameters. Like it starts with 6, it can go up to 7, 9, and 11 mm because of the thumb wheel design, which is precise and it is customized for the cage sizing. Lastly, we have the laser fibers. The commonly used size is the 200 micron because there's minimum deflection loss with this is at 10% as compared to the 365 degree, which has a loss of about 28 to 30%. There are various tip designs available, of which the ball tip or the track tip has the advantage that it doesn't damage the internal lining of the scope when it is flexed. And then we have the Bigopsy backloading biopsy forceps, which can be backloaded onto the flexible scope to obtain a sample from the kidney. So these are the various accessories that are available in the market. So we need to carefully choose the right one and stick to a few so that our surgery goes safer and easier.
Thank you, Manas. I think you have covered extensively.
You presented in time and very well depicted. Manohar, do you think that we should go for the next talk, because we are really falling behind, behind, because this online webinar I was slightly less strict. Otherwise, I might have.
So I'll call upon Dr. Edikulla. He'll be presenting on step-by-step RIS procedure without access sheath. Dr. Edikulla, over to you.
Yeah, yes. Can you share my PPT? I have given it to.
Okay. So we Edikulla, try to be in time, please.
Yeah, my presentation is short, sir.
Yeah, very good.
First of all, thank you, Chandramohan Vadi sir and other seniors for giving me the opportunity. Just excuse me as this is my first presentation like this. Okay, as the advancements in the flexible ureteroscope technologies and all the details described above, we are now having smaller scopes, and it is making our approach without the access sheath increasingly feasible and effective. And we have to consider a few benefits of the RIRS without access sheath. It includes during the access sheath placement, there is a possibility of ureteric injury during the dilatation process and trauma to the ureteric wall, including abrasions, and in very rare cases, it can lead to avulsions. Performing RIRS without sheath can avoid much of this kind of injuries. Access sheath itself is a costly affair, as in countries like our countries, the cost can be reduced by avoiding use of the access sheaths. It is having lesser radiation exposure, because most of the time when we place the access sheaths, we use radiation exposure. And when we are not using this, we can reduce the exposure to the patient and the operating staff and the doctors. The invasiveness also is reduced while avoiding the access sheath. There are many randomized control studies which is stating that the stone-free rates are comparable with those using access sheaths. This procedure is a comparatively simple procedure compared to the access sheath used procedure. Although the surgeon should be little bit experienced and expertise to negotiate the aortic orifice and do the procedure without access sheath. The anesthesia time can also be reduced, and the scope life can also be extended with avoiding the use of access sheaths. Then, coming to the potential drawbacks of the RIRS without access sheaths.
If you show the video step by step, it will be nice, sir. Do you have the video?
Yeah, I have a video. After 2 slides, I'll put down the video. Short video is there, sir. As there is no access sheath, the intrarenal pressure will be high, and there is a possible high risk of postoperative infections. And the operative time can be longer, because it may take much time to remove the stone fragments and finding out the fragments. And there is a risk of residual fragments retained in the kidney. That is more when we are not using the access sheath. The intrarenal pressure is increased, and there is concern for pilovenous and pilolymphatic reflux and postoperative sepsis. Then there are a few specific concerns while doing the procedure. That technical problems which we will meet is the aortic orifice can be very narrow. At times, we need to dilate the intramural part. There will be difficulty in negotiating the aortic orifice. In such cases, we can use a guide wire. Especially when it is very difficult, we can use a bi-wire to negotiate the aortic orifice. Bi-wire can avoid the scope of damage to the scope also. There can be a large median lobe of the prostate in males, so it also can be a difficulty during the procedure. Then tortuous courses of the ureter and acute kinks also can be very difficult to deal with. And then which all candidates we can select for sheathless RIRS is the next question. When the stones are smaller, we can opt for a RIRS without access sheath. When the stones are in accessible location, it is easier to use sheathless. Then in a selected patients where the access sheath is contraindicated, such as very narrow ureters, and when there is a stricture, sheathless approach can be used. Surgeon's experience is very important in sheathless RIRS. Can you put on the video then? Can you play the video I have given?
Yeah, video is playing.
Yeah. Here I have already placed a ureteric, placed a guide wire into the ureter, and there are some kinks in the ureter. That's why I placed a zebra guide wire to straighten the ureter. And then by manipulating the scope, I could negotiate the ureter and enter into the pelvic alical system. Once we enter into the pelvic alical system, then the procedure is almost the same as that of those using axial sheaths. This is an inferior calyceal stone. The rest of the procedure is same as those with axial sheath. Here we have to make sure that the stone is fragmented into very small fragments and powdered very well. Otherwise, larger fragments can be retained. And intrarenal pressure monitoring will be useful in cases where we are not using the axial sheaths.
If you take out one fragments also, it takes a lot of time. So better leave it the powder, or you will try to remove the fragments also.
Usually, when we are not using the axial sheath, we'll powder it to very small dust instead of making it into fragments. When there are
any guide wire outside any guide wire outside the ureteroscope is useful if you want to come out and go in.
I usually keep a guide wire. In this case also, I have kept one.
Outside
it is better because otherwise outside the ureteroscope.
Very good point.
Otherwise, it will be very difficult for entering the ureter and letting it out. And most of the time, the ureter will be having some kinks. That kinks will each and every time we have to negotiate the kink with the manipulation and all. And most of the time, I'll try to reduce the re-entry and keep the fragments inside the kidney itself. And later, if it is in the calyx, we can use it to fragment the rest of the bigger pieces.
Thank you. Can we conclude?
And in the literature also RCTs are available, and I would like to mention a meta-analysis that saying that uteric axial sheath leads to lower rate of postoperative fever and infectious causes. All other aspects like stone-free rates and uteric injuries are comparable with the both the approaches. Thank you.
The next moderator, please introduce Rakesh, and then we'll proceed. Who is there? Satish?
Dr. Satish, can you take over as moderator? Thank you, sir.
Good evening, everyone. Sir, is my screen visible?
Yes, 1 second. Is the moderator there? Otherwise,
yes, I'm here.
Yeah, Rakesh, you can proceed. Dr. Rakesh is a urologist at Hyderabad Preeti Kidney Hospital. Okay, proceed, Rakesh.
First of all, I would like to thank Dr. Chandramohan sir for giving me this opportunity. Today, I'm going to talk about step-by-step RIRS procedure with axis sheath. Is the screen visible, sir?
Yes, proceed. Limit to your time.
Okay, sir.
Enlarge the screen.
Sir.
Yeah.
So, to introduce RIRS is the minimally invasive treatment for renal calculi less than 1.5 centimeter. RIRS with axis sheath has many advantages, and it helps in early recovery with better stone-free rate. And recent development of FANS axis sheath has revolutionized management of large renal stones. So first I'll tell why axis sheath is important. So it reduces the intrarenal pressure. Axis sheath, if it is there, it reduces intrarenal pressure by directly draining the pelvic alical system. And if the outflow from the axis sheath is like this, drop by drop, then the rise in intrarenal pressure is very less. And one more advantage.
We can't hear you.
Hello?
We can hear.
And one more advantage is the vision will be good if there is a good outflow from the axis sheath. So we can see all the stones and better SFR. But at the same time, if the outflow is like this, as you can see here, this video, very less outflow from the axis sheath, then vision will be less in the endoscopy view. And we will ask our assistant to press more water. In that way, more internal pressure will rise. So the major disadvantage of RIRS is post-RIRS fever. That is the increase in internal pressure. As sir told, Deepak sir told, if the pressure goes beyond 40 centimeter, there will be pilovenous backflow. And if it is more than 80 centimeter, it will lead to fornicial rupture and perirenal hematoma and fever. So the major advantage of using access sheath is reducing the intrarenal pressure. Next advantage is direct access. We can easily go we can easily go like this video. You can see so many more times you can enter and go more frequent access into the collecting system. And again, it prevents ureteral mucosal injury. So suppose if you use directly scope without access sheath, we may injure the ureteral mucosa also if the ureter is tortuous. Now the next, this is a paper by Khaledi Hossain et al. They also told that if the use of access sheath helps in protecting the scope and increases the scope longevity. And if the stone is small, like 6 mm,
do you have any step-by-step surgery procedure?
Yes, sir. Yes, sir. I have, sir.
Please do that. Your topic, both of your topic were step-by-step. I thought you will show the surgery.
Sir. So how do I do it? Okay, sir. So the first step is I will calibrate the ureter with 7.5 French ureteroscope before doing the RIRS. I'll go with 7.5 French ureteroscopy. And if the ureter is accommodable and it accepts my ureteroscope 7.5 French, then I will be able to do the RIRS that day. And I'll go ahead. If the ureter is tight and narrow, we'll keep a stent and come out. Now, how to put an access sheath? Access sheath we put with two methods are there. The first method is fluoro-guided putting the access sheath. So in this method, after keeping a thick guide wire that is 0.2 or 3.5 guide wire, we'll just backload the access sheath under CM guidance, and we will keep on just gliding the access sheath over the guide wire. If there is any resistance, we will stop then and there only, like this. Now the disadvantage of putting the access sheath in this method is if there is high medial large medial lobe or high bladder neck, the access sheath may buckle. So what we use the method of putting access sheath is, this is a unique method of putting access sheath. We use 4.5 by 6.5 French wolf ureteroscope. Over this we backload this 9.5, 11.5 hook access sheath. This snugly fits over this ureteroscope, but we have to use this only, wolf ureteroscope 4 French and 9.5 by 11.5 French hook access sheath. Then this ureteroscope acts as the visual obturator, and directly under vision we will go into the ureter and we'll keep the access sheath like this. So in this way we can prevent injury to the ureter, and we can avoid high bladder neck also without any injury to the access sheath also. Now after putting the access sheath, as usual routine RIRS will go ahead and we'll go with the flexiscope, and then everything is routine. We'll just dust the stone fragment like this. Normally we use 110 Hz joule setting. Now, what are the benefits of using this access sheath? This is a paper by Lean et al. They also told this it helps in reducing the internal pressure, and the significant reduction in pressure leads to less post-operative fever and sepsis. And this study by Lucas et al. Also, they told ability to re-enter the kidney more frequently helps in shorter operative duration. And now the modern advancement is usage of fans access sheath. The flexible and navigable access sheath. It incorporates suction with lasing and improved vision, and it helps in better stone free rate in large stones. Now coming to a video of where fans access sheath is very useful. This is a partial stagon stone in upper pole biped system, as you can see here. And this patient doesn't want PCNL. And if you can see the RGP, this it is coming way above the 11.3 puncture and isolated upper calyceal stone. Here we kept the fans access sheath and started lasing at 1 joule 15 Hz. And there is continuous suction. All the dust fragments are getting sucked. Less rise in internal pressure, less infectious complication. At the end, you can see the RGP like this. And these are the dust fragments collected. This is ectopic kidney with stone failed open surgery outside referred to as it is a stented case. You can see the stone and pelvic ectopic kidney. Luckily, we could put the fans access sheath. Then we went inside. These are the multiple large stone volume. And we completely, no need to dust the stones in these cases, just fragment it. And then at the end, we can suck these fragments, large fragments like mini perk. These all will be sucked, and there will be less rise in internal pressure. This is the final RGP showing complete clearance. This is the elderly female with diabetes mellitus post pyelonephritis stented case. And again, this is a malrotated kidney, low-lying kidney. This patient also doesn't want PCNL hole in the kidney. So large volume stone. Again, we could put the access sheath ventricle. And these fragments will be able to clear with suction. This is the advantage of fan access sheath. This is the end RGP showing complete clearance. So this is a paper, recent paper by Felipe et al. They also told that the fan access sheath helps in enhanced stone-free rate. But what are the disadvantages of using access sheath? It's a paper by Olivier Traxler et al. They also told, it's a way back, 3 years back study, that injury to the ureter very less, like type 4 injury is only 4%, and there is 2% risk of ureteral stricture. This is a review article by Mehmet et al. They told there is no risk at all of using ureteral access sheath. There is no risk of enhanced ureteral stricture incidence. So my take-home message will be ureteric access sheath helps in faster recovery with less rise in internal pressure, and it helps in better vision. And with better vision, we can clear the stone completely with better SFR. So for beginners, at least, it's advised to use the access sheath and for better outcomes. Thank you, sir.
Thank you, Rakesh. Satish, introduce the next speaker.
We'll move on to the next speaker, sir, Jay Murugan, sir. He's a urologist from Salem. He also has extensive experience in RIRS, both in private practice. He's not attached to any government hospital. So we'll introduce Jay Murugan, sir. So Jay Murugan, sir, please stick to the time, sir. You can share your screen, sir.
No, your slides are not seen.
Sir, you need to share the screen.
Share the screen.
Share the screen, but he's not started this one.
Jay Murugan, are you online?
Yes, sir, I am audible.
Then share the screen. Time is short.
Sir, I'm sharing, sir, now.
Yes, sir. Screen is seen, sir, but a PowerPoint is not seen, sir. Just click on the PowerPoint, sir.
Close it and reshare.
I want to see, sir.
No, you open the presentation. You are showing the screen. You are not sharing the presentation. Click the complications of RIRS final.
That was, sir.
First, open the presentation before sharing.
So, open presentation, sir.
Yeah. Correct.
It's coming.
Yes.
Yeah.
Enlarge the screen.
So, slideshow on, sir.
Now, sir?
Yes, sir. Please proceed.
Yeah, sir. So, good evening to all. The greetings from Salem. My topic is on complication of RIRS. First of all, I thank to Dr. Chandramohan sir and Dr. Satish giving me the opportunity to present this topic. And special thanks to Dr. Vikram and Karthi for providing the material. So, RIRS is a retrograde surgery done above PUJ. Though it is relatively very safe procedure, it hides potentially dramatic and fatal complications. There are some risk factors that increasing the complications are divided into patient-related factors and procedure-related factors. If I'm comparing to patient-related factors, I always say the pre-existing urinary tract infection is one of the most important factors affecting the increasing complication rate. And coming to procedure-related, prolonged time, I used to restrict my surgery below 1 hour and always avoid high irrigation pressure. Going to classification, it can divide into intraoperative, early postoperative, and late postoperative complications. Due to time constraint, I will list the only important complications briefly without going into much detail. So here, clavite window classification also you can see bleeding, fever, UTI are one of the most common complications after RIRS. So for the younger urologists, those who have started to do RIRS, the US related injuries are more common. So always should be avoided. Some tips for how to pass UIS. I always inspect the ureter with semi-rigid ureteroscope before inserting the access sheath to look for any tight ureter or any king. So make sure your bladder should be empty and always pass the guide wire or access sheath under the same guidance. Never use jelly in the access sheath. Most of this we use in previous also. I am also using jelly over the hydrophilic coat. If you apply jelly, it will coat the hydrophilic area, then it will make sticky, so it will be very difficult to remove it. And once you get expertise, then you can go for sheathless. Remember, there is always another chance, only when the patient is safe. So you can see, so we have to, when you're passing guide, you should be very careful. Otherwise, you go into submucosa and make a submucous tunnel. If you see the like a tight ureter, never advance scope or ureter access sheath. It may cause injury and false passage and mucous interception. So this is the access sheath induced injuries. It's already seen by previous presenter. So I'll go to the next slide. Avulsion. Avulsion is a very rare and underreported. Usually due to you are pulling against resistance of the basket or the scope against resistance. So we have to be very careful when withdrawing the scope or basket. This is one of the next. The instrument related complications. Here you can see the basket disconnection. See, after basketing, so basket got disconnected. It was removed by forceps. So stuck basket. Nowadays, after introduction of flexible digital scope and TFL, the usage of basket is very much declined nowadays. This is in practice. So this completion nowadays is very rare. So always you take utmost care when using the flexoscope, because flexoscope is the most costly and important tool in RIR. Should be handled with very utmost care. If you give undue torque or force, it may get break in the distal part of the scope, or lever system may get damage. So digital firing, always keep eye over the blue line. Otherwise, sometimes ASU fiber can descend into scope. It will cause damage to the scope and loss of vision and loss of scope. See, you can damage the fire. You should not always keep a blue line. Otherwise, it will recede. Extra obsession. One of the another complication following RIRS, you should keep internal pressure very minimal. Otherwise, it will cause fornicel rupture and cause extra obsession. The fluid can collect in either retroperitoneum or intraperitoneum. If you diagnose intraoperatively, you always put PCD and drain the all fluids. So bleeding, one of the common complications, bleeding in RIRs is mainly due to the high intrapelvic pressure. Scan injury can be caused by injection of contracentral pressure. Sometimes a guide wire and tip of axis also can cause mucous injury and bleeding. Laser fiber also can, while firing, laser fiber also can cause bleeding. In my early days, I have faced these complications due to inadvertent use of mucous injury by laser fiber. So what risk factors bleeding RIRs are history of previous surgeries, disordered collective system, prolonged operative time, and more important is high pressure irrigation. So you can see the vicious cycle. If high intrapelvic pressure leads to fluid absorption, high intraoperative BP, bleeding, to increase irrigation fluid pressure, to clear fluid, again will cause high intrapelvic pressure. Hemorrhage can be minor or major. So you can see here is a minor bleeding. There, this bleeding can clear by itself by just increasing the fluid rate of irrigation. Once you get heavy bleeding, sometimes it may need coagulation of vessels. When identifying any bleeding vessels can be coagulated with the coagulation mode. Sometimes after post-infant velotomy, you can get a severe bleeding. If it is severe bleeding, please abandon the procedure, put stent, and come back with bladder should be irrigated with 3-way catheter. So always you commonly think the A fistula and atrial fistula commonly occur after PCNL. Even retrograde surgery also we can get this type of complications. It is all it comes in the literature. If it happens, we have to go for selective angioembolization. So how will you prevent? So always maintain the low irrigation pressure, just enough to have a clear fluid. Always watch out the intraoperative BP. This is very important. Synchronize the laser firing with respiratory movement. Infant velotomy, you always give multiple superficial area cut. Don't give any deep cuts. Avoid high-frequency laser setting near to the mucosa. It will cause damage to the mucosa, cause bleeding. Consider GA in the initial period of time. So coming to late complications are late. It is the subcapsular, another complication, subcapsular hematoma. Another is intrarenal hematoma. This patient has actually phase is referred to me. And outside they tried your RIRS. Infectious complications are increased factors are the factor risk factors are increased intrarenal pelvic pressure, irrigation.
Sir, last 1 minute.
Okay, sir. Okay. Coming to how to prevent sepsis. So always you do urine culture prior to the procedure whenever possible. Ensure sterilization of all accessories and avoid procedure case system even in sensor system. In case of doubt, please change the procedure. And sepsis always keep eye on the pulse, BP and saturation. Don't never hesitate to go for iron antibiotic and also keep antifungal treatment also in immunocompromised patients. And you have very low threshold to start inotrops whenever needed. So safe practice to reduce the complications are right case selection, ensure accessibility available. The very important point, spending 30 minutes pre-operatively is better than spending 2 hours after complications. Always handle scope with the accessory with the care. And a very important point is have a mentor for initial cases can overcome learning curve fast. So order of priorities are safety of patient, safety equipments, logic, cleaning of stones. Thank you.
Thank you very much. Nice presentation, in fact. Good collection of the complications. Now, can we go to the next presentation, please? Kandar Parik, sir, if you bear with us another 10-20 minutes, we will discuss at the end, maybe 5-10 minutes, please.
Yes, sure. No problem.
Sorry, sir. We overshot.
No, it's fine. Perfectly all right.
Because online webinar, we have to give some.
Correct. No problem.
Yes, please. Mr. Rajnikant.
Yeah, thank you, ASU, for this thing. I'll be very brief. Mostly whatever I'm going to say has already been said. I'll just detail on how I do a large stone RIRS. So this is basically more about my practice. So why I do RIRS in a large stone? Because I'm comfortable with PCNL. It's mostly about patient demand. Once a patient comes and he says that he wants an RIRS, even I'm speaking about a large stone, a 3 centimeter stone, a partial staghorn, maybe sometimes even a staghorn, the patient demands for a RIRS. His whole idea would be downtime. He will be able to go to the office next day or 2 days after. Then bleeding diastasis. In bleeding diastasis patients, RIRS is preferred than PCNL. So I do only when the patient demands it or when it's absolutely necessary. Otherwise, PCNL is my first option. The guidelines also support, though not first option, it also supports doing an RIRS. So it's not wrong to do. You have guideline support for doing an RIRS. And the most important thing is, it's not for all patients. Be very sure about the patient you are going to do. The patients with very high demands, the expectations are and they are very high. They want all the stone, all the fragments to be cleared, especially in one sittings. They don't want to come for a secondary procedures. I don't take those type of patients. I tell them RIRS, unlike PCNL, I'm not very much going to sure about the stone-free fragment, especially first procedure, and not all stones. An infected stone, the patient has history of sepsis and all those things. Be very careful. Treat the infection. Make sure that you have a good antibiotic coverage before the procedure. And a pre-op investigation, always a CT, preferably a contrast in a CECT urogram, or an NCCT will do if it's also okay, but a urine culture before the procedure. I always tend the patient under local anesthesia using a flexible scope due to the financial issues in the OP and send them home and bring them back after 3 weeks or 1 month for a RIRS. So pre-staining is always done for a large stone in my unit. The position, it's general anesthesia, it's never spinal anesthesia, and the position I usually keep the side, the ipsilateral side little higher than the other side, and the head slightly down, so that all the stones or the fragments will go to the upper calyx where it can be easily dealt with. So this is basically my setup. I have a 7.5, preferably 6.5, 6.3, which you have now, but the go-to one is the 7.5 French scope and a flexible FNAS. With FNAS, with the introduction of FNAS, we are more comfortable. The stone-free rate has gone up. The sepsis has started coming down. So a pre-stending, a larger size access sheath can be kept. The size of the access sheath versus the scope size, this is just a study which shows that with when there is a greater disparity between the size of the inner diameter of the access sheath and the scope, the velocity of the flow is good, and all the fragments, all the dust gets absorbed, and there is lesser chance of a blockage of the access sheath. About irrigation, as we all know, irrigation pumps, manual irrigation, gravity, or the gravity assisted thing. But gravity assisted, though, is supposed to be more safe. We have at time we want some little more pressure to clear the system. So what I do is it's gravity, but we have a pressure, the manual pressure compression device, the Pathfinder attached to it, and our staff has been very well educated about the problem with high renal pressures. They have seen the complications, so they'll only give 1 or 2 pressures. That's a slow compression when we ask them to do. Otherwise, the thing is left hanging down. Nobody can keep it in their hand. So one of the most important thing about RIRS in last one is this is going to take a long time. So your comfort, your fatigueness is going to affect a lot about the results. So I would rather sit in a chair, comfortable chair with an armrest. My hand resting on the armrest, sitting comfortably. And one of the thing is that most of the time it is the laparoscopic tower that is kept there. So it is usually a little high. So you have to keep your head slightly this thing, and you'll start having neck pain. So the scope, it's better to have a separate stand for your RIRS with the scope at the level of your head. So you can sit straight, stare in straight with a straight neck. Another thing is don't sit facing the patient. Sit slightly turned to the right side so that you can look at the scope, look at the monitor and this thing without turning the head, neck. So ergonomics has to be carefully looked into. Then catching the scope. So palm grip, the problem with palm grip is longer time you are doing this, you actually will have pain in the interphalangeal and the metacarpal phalangeal joints of your thumb. So actually ideally a finger grip actually you catch your scope little more distal, use your fingers to catch the RIRS, the thumb will start paining less, and you'll have more maneuverability using that. And laser fibers. Having both holmium and high power holmium or a thulium is must. Either a high power holmium or thulium is must. But while doing large stones, I have found it useful to use a combination of both. So because I'm slightly afraid of using the thulium fiber inside the pelvis, so what we start with holmium fibers with a higher wattage, and we try to break the stone into 2, 3, 4 pieces, which is manageable, and then if at all possible, push it into the
last 2 minutes, sir.
Push it into the calyces. You use thulium fibers to finish it up. And one thing that you can always try is different stones behave differently with different energy settings. You can actually start breaking down and then start playing with the frequencies and the power. Slightly change the power and the frequency here and then, and see which works for this stone the best. So this is my setting for a thulium laser or thulium RIRS. The concerns would be for doing a large stone, intrarenal pressure. It has been already spoken about the infection load, the indwelling time. The longer you are inside the pelvis, the higher chances of injury, higher chances of sepsis. And the scopes are still costly. The scope wear and tear, especially with the flexible accessible FNAS, if you go out and in through the flexible scope multiple times, flexible access sheath multiple times, the scope wear and tear is high. That's it. This is a systematic review and a meta-analysis comparing RIRS with PCNL. Thank you, sir.
Thank you very much. In fact, Kandar Parikh sir, what is the largest size stone you have done, sir?
Chandramohan, I have done, I mean, I'm not in a very much favor of doing
Yeah.
ARS for a very large stone. That is one thing. That beyond 2 centimeters, still I believe that we are not ready, because you can, if
Very
you
good
want
message, sir.
very nice dusting, you will leave behind some fragments that you need to take out, and you take a lot of time, and you sometimes may lead to complications. So,
Sir,
but
as Rajnikant sir said, after coming fans, have you increased the size of the stone to be dealt with RIRS, sir?
yeah, you can do it, but I think you need to have a good experience with the fan sheath also, because we are not very much aware of the complications led by the done by the fans. So you have to be extremely careful, but especially the youngsters. Secondly, because some people are posting, videos of stag-on stone being done by RIRS. Experts can, maybe they can do it. I am not ready for it.
Even I have not done, sir.
Yeah, but the only one thing I want to say that, Chandramohan, that you have to have a look at the HU. Supposing I have done a very large stone when the patient was not ready for the PCNL, and the HU of this stone was around close to 700, 800. This was a very soft uric acid stone, which I could do it very fast, very quickly, even if the stone
Right,
size
sir.
was more.
Okay,
So I
sir.
think HU, if you can
Next
look
speaker.
at.
Right, sir.
So
I
can
got
you
the
see my
point.
slides?
No HU units you can do, but not IHU units. Okay, next speaker, please.
Can you see my slides, sir?
Yeah.
Yeah. So good
No,
evening,
no,
everyone.
no. You have not shared. You are not shared. Sorry. May I take the fourth moderator today? Yeah.
So can you see the slide now?
Yeah. Yes. Good.
Yeah.
Proceed, Syed Jahid Raja.
Sir, good
RIRS
evening.
in anomalous kidneys.
Yes.
Okay.
Good evening, everyone. At this outset, I would like to thank the ASU and Dr. Chandramohan sir for giving me this opportunity. My topic for today is RIRS in anomalous kidneys. I would like to start the presentation by saying whether RIRS is being done in a normal kidney or an anomalous kidney, the principles do not change. What we have to understand is we need to know what can go wrong. So anticipate and be ready with troubleshooting and be ready with plan B. Now, it's something similar to driving a car in a new city with new rules. If you know the rules, the probability that you will get into trouble is very less. Now, this is a study published in Gold Journal of Urology, January 2022, where a lot of prominent urologists across the globe came together and they gave us the outcomes of doing RIRS in anomalous kidneys. And the incidence, what they showed, the commonest of anomalies were horseshoe kidney with 29%, and the least common was polycystic kidney disease of 1%. Now, what are the challenges we face? It's the difficult ureteric access because of probably the length of the ureter, be it in pelvic kidney or the obstructed systems in a duplex system, and abnormal calyceal orientation in horseshoe kidney or a malrotated kidney, and working space and scope deflection also is a challenge. Now, enough has been said, but not enough has been said about high intrarenal pressure. An excellent talk by Dr. Deepak Ragori sir, emphasizing the importance of intrarenal pressure. Now, how do we prepare for an anomalous kidney? A good CT urograph to understand the anatomical mapping and the relationship of the stone to the pelvic calyceal system. Positional modifications, I think there was a good presentation mentioning a couple of modifications. Scope deflection and laser fibers. Now, this is the single most important point, what I feel. Now, these days, there are better scopes with good degrees of deflection and smaller scopes. That is owing to the availability of thulium fiber laser, because of which smaller diameter fiber is a possibility than a dream. Now, a safety guidewire is also important, especially when you're doing a sheathless RIRS, and also it is important to have an exit plan. Now, just briefly talking about horseshoe, each of the anomalies. Now, this is a patient which I did recently, wherein in a horseshoe kidney, the renal pelvic stone was there. I cleared the stone The problems what we face is the position of the kidney is very low lying and mild rotated anteriorly facing calyces and high inserting ureters, which will probably not allow us to do ureteroscopy and pass the access sheath initially. We might have to stage the procedure. Now, the same CT patient, the CT which I showed, this is a check RIRS which I did after 4 weeks. This is because I found there were residual fragments. You can see the anteriorly facing calyces. Now, there were a residual fragment, one small fragment in the lower calyx, which you will see now, which I'm not worried about. But there is an upper calyceal, this calyx, which was very superior and too medial for me to enter. And with great difficulty, I was able to enter it and clear the stone. Now, another important point in such anomalous kidneys is that migration of the stone. The CT showed a pelvic stone wherein I was able to fragment it, but few fragments went into the upper calyceal stone, making it difficult for me to visualize initially. So I had to go back and relook. Now, ectopic kidney, again, it can be aberrant location right from the thoracic kidney to a cross-fused ectopia, and this having an aberrant orientation of the calyceal system as well. Like the horseshoe kidney and the ureteral anatomy. I would like to emphasize more on the ureteral anatomy in this aspect because the ureter sometimes will be short and tortuous and the entry itself might be difficult, and passing an access sheath through the lower ureter might not be very easy. Which will tempt us to do a sheathless RIRS. But again, I have lost a scope while trying to negotiate in a difficult ureter. I would request everyone to be a little careful, do an RGP, see the size of the stone. If the stone is smaller in size, probably then attempt a sheathless procedure. Otherwise, again, a better procedure for it, probably a laparoscopy assisted PCNL would be better. Now, coming to the duplex system, identifying the right ureter is important. Now, why is it important is because we know that in complete duplication, the ureteric opening might be a little lower down and medially placed and making it a little difficult because it can be obstructed as well. And in an bifid system, there might be a chance of missing the correct moiety if you don't do an RGP. So I would request, I would prefer doing an RGP before doing this procedure. And also poor drainage of the affected moiety means that probably there might be infection, and I would rather stent the patient first and then probably take up the patient again. Now, this is a recent case I did again. It's a duple moiety. What I wanted to emphasize here is the lack of space to work with here. You can see the stone occupying the infundibulum and the narrow calyx is seen on RGP. Now, for this, I would first tell the anesthetist that it is going to be a little difficult for me to keep my scope steady. So I would request him probably to decrease the tidal volume, help me with the respiration, and in between apnea, and try to use lower energy settings, trying to be as careful as possible, trying not to touch the mucosa and cause bleeding. If once bleeding occurs,
last 2 minutes.
Yes, sir. Now, diverticular stones, again, it can be easy, but can be nightmare as well. If you see the diverticulum opening, you can incise and then probably go ahead and clear the stone. Here, one point I want to make. Earlier, I used to use a long pulse width, which was causing that woolly sort of an appearance. But again, if you use a short pulse width, it will be properly incised. But no matter what, sometimes you will have to have patience. You will enter the wrong plane. That time you have to reassess with the help of C-arm. Or you can use a methylene blue, wait for all the methylene blue to be excreted out, and then you will see the calyceal opening, and then probably accept defeat and stage the procedure if at all you are not able to complete the stage. This again is looked like a straightforward case wherein it was a lower calyceal calculus. I had missed these stones, but on careful examination, it was a flimsy web like this covering, which I incised and cleared the. PUJO, again, if at all it's a complete congenital PUJO, I would probably stage it after doing, if suppose you want to do an endopilotomy, you will stage it after doing an endopilotomy, then second stage. But the important point is the drainage. These kidneys are very poor in drainage, so I would probably use a fan's sheath in the second sitting and try to clear out the whole thing to give a clearance, to give clearance. Now, coming to ADPKD, the calyx is displaced and distorted, which makes it difficult to orient ourselves under fluoroscopy. There is reduced working space and difficult access to the ureter as well. All these points again point out to the fact that we need to probably stent the system first and then later on come back again. Now, what things to do to overcome these challenges is a good preoperative workup. Ureteral access sheath is better because we keep going in and out and we are going to stay in the system for a long time, and you should have a very low threshold of staging for the safety of the patient and also to prevent scope damage. Thank you.
Thank you. Everything I agree, except I hope Kandarpanik sir also. In PUJ obstruction, if you suspect, be very, very, very careful about doing RIRS.
Yes.
Unless you wanted to do endopilotomy, which is not a successful procedure.
Yes.
So do pyeloplasty and then stone removal. In case if you do endopilotomy, again passing a FAMS access sheath across, slightly because it heals by fibrosis and it may tear again. So we should be careful. Rest of the presentation is very good. Now we'll move to the next speaker, Dr. R. Raja, various lasers used in RIRS. Dr. Raja?
Hello, sir. Am I audible, sir?
Yeah. Raja Ramesh.
Yes, sir. I'm sharing my screen.
Yeah, please. It's screen shared. Your make the screen bigger. Yes, thank you. Proceed.
Yeah. First of all, I thank Dr. Chandramohan and Dr. Satish Kumar for giving me the opportunity to speak in this forum. And congrats, Dr. Chandramohan, sir, on the first telerobotic pyeloplasty in a pediatric age.
Okay.
My topic is lasers used in RIRS. This topic has been is more of physics rather than our technical biology or medical terms. So, going with this, I'll be speaking. I had divided my talk into a few topics: laser basics, OYAC, TFL, thulium YAC, what are the pulse modulations, how to do fragmentation dusting. So, laser stands for light amplification by stimulated emission of radiation. And how does it disintegrate the stone? The mechanism of action of laser, it can either be photothermal or photomechanical. Photothermal, the photons emitted by the laser can be directly absorbed by the stone, and that causes stone ablation. The water or the urine inside the stone can absorb the photons, expand as bubbles of gas, resulting in cracking of the stone. A water near the stone can get vaporized, and the expanding bubble can cause stone breakage. For a photothermal effect, a contact or a near contact mode is preferred. For a photomechanical effect, it depends upon the irrigation fluid. The irrigation fluid water absorbs the photons, resulting in cavitation bubble formation. And as the bubble ruptures, it sends water jets, resulting in stone fragmentation. And this doesn't require any contact with the stone. What is laser power? We have seen lasers of a lot of powers, high power, low power lasers, TFL, variety of things. So laser power is determined by the energy of each pulse of the laser and the frequency of pulses. So power is energy into frequency. So what importance is for the same power, say 10 watts, usually we use around 10 to 20 watts maximum for stone breakage in RIRS. So for same 10 watts power, I can use 0.25 joules at 40 hertz or 1 joule at 10 hertz, depending upon the effect of fragmentation or dusting, which I like to achieve. So next comes the terminology for lasers. Laser pulse. Laser for stone fragmentation is not a continuous wave laser. It's an intermittent laser or pulsed wave laser. It's emitted in small pulses, which is measured in either microseconds or milliseconds. Now, the pulse has a few characteristics which you need to understand. One is called the pulse width. It can be short, medium, or long, as shown in the picture. Second is the peak pressure achieved during each pulse. And third are the varieties of pulse modulations available with the modern laser machines. Going to the pulse width, it is the duration of pulse. It's measured in milliseconds or microseconds. It can be short, which is less than 0.2 milliseconds. The shorter pulse will cause a better fragmentation, but it has more chance of retropulsion. When the pulse length or pulse width is long, more than 1.2 milliseconds, it causes lesser retropulsion and results in dusting of the stone. So peak pressure. The peak pressure, you can see the graph here. So this green line, this represents the pulse wave of a Hoyak short pulse. You can see the amount of pressure as soon as the pulse wave begins goes peak and then suddenly drops. So such a high pressure generated will cause a lot of retropulsion. At the same time, results in fragmentation of the stone. Next comes the long pulse of the Hoyak, this red line here. Again, though it's not as high as the short pulse, the long pulse is slightly longer, but it still has a very high peak power, causing retropulsion of the stone. Coming to thulium fiber laser here, this blue line, which has a short rise in power, the peak power stays flat throughout the long wave and then goes down. So this causes more effective dusting and less retropulsion of the stone and finer dusting of the stone. Now with the pulse modulations, with the Hoyak, we have something called a MOSES technology, which is a double pulse technology, where a large pulse is there, followed by another small pulse. Now they're supposed to be causing lesser stone fragmentation. However, we'll see on that. So this is the importance of peak pressure, especially in relation to stone retropulsion and stone fragmentation.
Yes, next slide.
So by modulating these pulse frequencies and other pulse width and energy, we should be able to either finely sculpture the stone into small dust-like particles or grossly break the stone into big chunks as per the need. So current lasers which we are using are Hoyak, TFL, and recently we have thulium YAG laser. Of course, it's an old laser, but for stone management, it has come up now in a pulse modulation. So going with the Hoyak, Hoyak can be either low power, usually up to 65 watts is considered low power, or a high power laser, which is between 100 to 150 watts. Now, how the laser energy is generated? Hoyak contains a flash lamp made up of krypton or xenon. The flash lamp generates light. These photons are sent into a resonance chamber. The resonance chamber contains holmium YAG. And when this, because of resonating chambers, the energy and the photons get streamlined and are emitted as a laser. Now, for a low power laser, there will be one resonance chamber. And if we go for a high power laser, there will be multiple resonance chambers. Usually, on average, around 20 to 30 watts can be generated by a single resonance chamber. Depending upon the energy used, the number of resonance chambers can vary. Going with TFL laser, a thulium fiber laser. Here, we don't have any flash lamp. It's a continuous diode laser. The diode laser emission is passed through 30 meters of thulium doped silica fibers. Now, when this is passed to 30 meters of thulium doped silica fibers, it becomes a thulium fiber laser and is emitted out. So this is the basis of or functioning model of thulium fiber laser. So now let's look at a comparative analysis between both the lasers, holmium YAG as well as thulium fiber lasers.
Last 2 minutes.
Yeah, yes, sir. So the wavelength, as you know, it's 2100 and 1940. The water penetration depth is very shallow for thulium fiber laser. It means it gets rapidly absorbed in the water. And Hoyak, there's no continuous pulse possible because it's a flash lamp based laser. And the main difference is the frequency and the pulse width. The energy settings are almost the same, but the pulse width which we can achieve is only 1 millisecond. It's the longest pulse which you can achieve with the Hoyak laser, while you can go up to 50 milliseconds in a thulium laser. And that's the frequency. Because there are multiple resonance chambers and mirrors, the frequency cannot be more than 100 or 120 hertz, while in thulium it can go up to 2000 hertz. And the smallest fiber currently available Hoyak is 200 microns, while the smallest fiber in TFL we have up to 50 microns. Now, this is regarding the depth of water penetration depth and the usability or the accessibility of this laser. Now, the Hoyak is a very heavy machine, weighing easily around 200 to 300 kgs compared to TFL, which is around 40 to 50 kgs. And the energy efficiency for the amount of power the Hoyak consumes, only 1% is emitted as laser. For TFL, up to 12% of the energy it uses is emitted as laser energy. And a HOYAG, a high power HOYAG, definitely requires a dedicated 440 watts industrial socket. This requires rewiring of the entire operation data complex, while a TFL can be used in any 15 amp socket. But if and other advantage differences is the low power HOYAG has a water-based cooling system, while high power has a dedicated refrigeration-based cooling system. While TFL uses a small fan, just like something which we use in a laptop. HOYAG has a lot of moving parts or a lot of optical parts like blast shield, mirrors, and prisms. There's nothing in a TFL. It's just a loop of fibers through which the energy is passed. And regarding maintenance, the companies charge a huge amount for AMC. For TFL, there's no concept of AMC, and it's a very sturdy laser. Also, TFL seems to be more advantageous. But what's the problem with TFL is there's a lot amount of heating. Like it heats the water a lot, and this can cause damages to tissues, especially the ureters. And when we use it for tissue cutting incisions, say for doing infundibulotomy or other things, it causes charring. Now, thulium YAG is again a diode laser, similar to comparison with a HOYAG, but instead of a xenon or krypton lamp, we have a diode laser, which is resonated through a thulium YAG crystal resonance chamber. The
last 1 minute.
The parameters are somewhere intermediate between holmium and TFL. It can be used in both continuous as well as intermittent pulse modes. Now, the pulse modulations, commonly the first thing which came in is MOSES technology, which was promoted by luminous lasers. Here, there are two pulses. One pulse creates a tunnel, water displaces the water and creates a tunnel. And the second pulse reaches via the tunnel directly to the stone, resulting in more efficient fragmentation and lesser retropulsion. Next is the virtual basket. This is by Quanta Medical Systems. Again, it's similar to double pulse emission, similar to MOSES mode. But here, what they say is the first mode creates some sort of a suction effect, preventing stone retropulsion, and the second one helps in fragmentation the stone. Third is the vapor tunnel, again by the Quanta Medical Systems. Here, as you can see, the pulse length is very long. It's a very long pulse with a minimal peak power. So stone retropulsion is less and it has better stone dusting capability. So these are the preferred modes of.
I'm not conclude, Dr. Raja sir, please.
Yes, sir. In
conclusion slide.
It's better to use a high energy, a low frequency, and a short pulse. If you want to go for dusting, use a low energy, a reasonably high or controllable frequency, and a long pulse width. So, thank you, sir.
Thank you very much. Good presentation. I know the time is less, but you are crisp. You conveyed the message. The one slide, if you have shown this laser settings for different different stones and different HU densities and sizes, it might have been better. Otherwise, good logistics you told. Next speaker is the last speaker, but last speaker will be given full 10 minutes time. We will not give any disadvantage to you. You speak well, Mr. Bradishwaran from Tamil Nadu, Tanjavur. Over to you. Bradishwar, unmute. Bradishwar, unmute. Bradishwar, we are not able to listen you. Increase the...
Sir, can you hear me now?
Yes, please.
Yes, sir. Can you see the slides, sir?
Yeah. First slide, you go back.
Okay.
Yes.
Can I start? Is it okay, sir?
Yeah, please.
Sir, good evening, sir. I'm Dr. Bradishwaran from Tanjavur. I would like to thank ASU, Dr. Chandramohan sir and Dr. Satish sir for giving me this opportunity. I'm going to talk about the future technologies in RIRS. So what to expect in future, that is, the essential thing is robotics, next generation lasers, smart ureteroscopes, advanced imaging, smart accessories. All these things has to be incorporated with artificial intelligence. So the current issues, practical issues we are facing is technical challenges, surgeons fatigue, high cost, radiation exposure, residual stones, complications, narrow ureter. So Coming to robotic system, as we all know, robotic system in other departments and especially neurology also has been very well established in India. Even in two-tier city, we have got a robotic system nowadays. But soon, I think we will get a robotic RIRS system also. As abroad, they have started using it now. So the main advantage is to operate in a seated position at a console with a magnified view, which it significantly reduces the physical strain, fatigue, and it improves the performance in long cases. It increases the precision and stability, especially in complex and large stones. And it's also very useful when the kidney is moving fast while operating. This is also very useful during that time. And the surgeons and the surgery team have a very low radiation exposure and sometimes no exposure at all. So this is a picture showing the robotic system. It's a integrated Korean made is ureter integrated control of laser fitted with the robotic system. It's been used in Korea. The picture shows this is first picture shows a master's console with a slave manipulator. The second one shows a jog wheel like a jog stick, and this is one with the mounting part of the slave manipulator. Here the surgeon can operate from the main master console without any strain. So this is a short clip I would like to show. There is a surgeon is fragmenting the laser using a robotic system without any strain at all. This is a second clip showing the after fragmentation, it has been basketed very well nicely without any strain using the robotic system. So coming to the advanced laser technology, that is now we have a holmium laser and thulium laser. There are pros and cons for both holmium and thulium. The main advantage of holmium is very powerful, but the retropulsion is very high, and the advantage is heat generation is comparatively less compared to thulium, where the heat generation is more, but it is very efficient in dusting the calculus. So we want in the future, we want the combination of both holmium and thulium, that is a powerful as holmium and efficient as thulium. So they recently the Qantas they have introduced a cyber holmium generator with magneto technology. Here what happens is by achieving the low peak power levels, the stone retropulsion is significantly reduced compared to standard holmium and thulium. The direct connection between the fiber tip and the stone enhances the energy delivery. So the system reduces the fragment size, making extraction even more easier without using any basket. So already it's been discussed about the virtual basket. That is, it is a double pulse modulation technique integrated into this device, reaching the high power up to 152 watts with a frequency of 100 hertz. It allows a low retropulsion with the fragment suction effect. So it is a great tool for operating in harder and very large stones. So already a study has been conducted by Perry et al. At Italy. They have done a study in mini PCNL using this mission in 10 to 20 mm of renal stone. That is, they have conducted in 50 patients between last year, that is April and October 2024. The mean stone size is 16.8 mm and the mean house filled unit is 1042. The mean operation time is 57 minutes. The laser time is 16 minutes. And the delivery energy is 9 kilojoules. The stone free rate after the surgery is 96%. There are very minimal complications like urinary tract infection, hematuria, and pain. So they have confirmed that it is a feasible, safe, and effective with high stone dusting efficacy, reduced operating time, and with less complication risk. Actually, further studies are needed to compare with these other lasers also. So coming to laser fibers, now commonly we are using 200 micron fiber, and latest the 150 micron also been available in market right now. We can expect as small as 50 micron in the future. That will improve the ureteroscope's flexibility and access to the very tight spaces and difficult calyxes. So coming to single-use flexible ureteroscopes, it eliminates concerns about the scope damage, image quality, reduced deflection, reduced cost, low risk of infection, and it should be made with balanced features like not only the smaller size, but the channel for irrigation channel as well as the laser channel should be as adequate. And the future miniaturization is possible. Small diameter scopes are all available right now. Now we are using a 7.5 scope. And coming to virtual, then is other advancement is virtual ureteroscopy. This technique uses computer-driven construction to create a non-invasive, high-resolution endoscopic view of the urinary tract, which may be useful surveillance method in the future. And also, we can also expect a robotic-assisted ureteroscope with sensor also impregnated with artificial intelligence. So this is the scopes we are using right now, commonly used scope. The below one, black one is Flex X2. It's a reusable scope. This one is a huge single-use disposable scope, which is 1.5, which is 1.5 French and very lightweighted, and the image quality is very good. And soon we can expect a smaller scopes. Now it's a 6.3 French scope is available ready in the market. In this scope, we can easily access the very difficult calyx and the narrow ureter, and we can use 200 microns as well as 150 micron fiber in this ureteroscope. So this is the evolution of the single-use disposable scope. In 2020, it was initially 9 French. You can see the blue circle, and 2022 is around till now it's around 7 French that we are commonly using. And 2024 they have introduced a 6.3 French. In the future, we may expect even much more smaller ureteroscope, maybe even less than 5 French also we can expect. Coming to smart accessories, there are smart accessories which we want. Expandable, if we have, imagine if you have an expandable urethral access sheath, especially very useful in case of a very narrow ureter, and with integrated suction with sensor also. And we want access sheath with intrarenal pressure monitoring is there. And that magnetic, another technology like it's developing like magnetic hydrogels to coat the stone fragments that can be removed using a magnetic wire. Coming to imaging and navigation, it's a dual modality imaging, that is fluorescence and augmented reality. It's a combination. It's the use of fluorescent dyes to better visualization of a stone or a tumor in the upper tract, which overlays the patient's CT scan or imaging data onto the live endoscopic review to guide the surgeon more precisely during the surgery. So the other methods of imaging is like endoscopic ultrasound and optical coherence tomography. These imaging techniques can provide real-time high-resolution analysis of renal tissue and assist in targeting the laser for stone ablation. Then other thing is a stone morphometry analysis. That is, advanced software can also be introduced that can analyze the stone's shape and composition preoperatively and intra to help plan the most effective surgical approach to the patient. Then coming to adjunctive technologies for stone clearance, there is a targeted section which developed to integrated ureteroscope channels and special device to actively suck the stone dust and fragments. The smart access sheets, that imagine an access sheet with integrated pressure sensors that alert the surgeon to dangerous pressure spikes, and miniature baskets like it should be durable and capable of capturing very small fragments, and also with sensors to avoid putting bigger fragment. Then hydrogel-based technologies, as I told before, so emerging concept like hydrogels that can be temporarily placed in the kidney to help collect and remove fine stone debris. And automated irrigation, that is, it describes a system that automatically regulate the irrigation pressure, minimizing the risk of high intraluminal pressure causing complication. The last but not the least is artificial intelligence in RIRS. All the systems, artificial AI is like emerging very big actually now. So it should be trained to automatically identify the stones and fragments during surgery, especially identifying the residual stones, evaluating the surgery process, and optimizing the laser parameters to different stone types. And also it should be helpful in real-time decision making also during intraoperatively. And it also can analyze the preoperative data to predict the stone-free rate and identify the patient who may require the second intervention. And then there should be automated navigation which remembers the path for the repeated access with sensors, and also safety alarms to prevent grabbing the oversized stone. While doing all this, there should be haptic feedback. You should feel the resistance with the haptic feedback. Then the complications can be avoided. And the final thing is about the training and for the surgeons, like virtual reality with AI-driven simulators are being developed to train surgeons in RIRS technique. The conclusion, future will involve a convergence of new laser technology, advanced instrumentation, robotics, and AI assistance. RIRS technology will focus on improving patient safety, increasing surgical efficiency, and enhancing the overall stone-free rate. The ultimate goal is to provide more precise, less invasive, and safer treatment for patients with upper urinary tract pathologies. Thank you.
Excellent presentation. Though it is last presentation, I must congratulate you. Pradeshwam, you are very good. So now because Dr. Kandarp Sarik is there, 100 audience are there. We will take quick questions, Sir Kandarp sir. It's like MCQ questions. No, this thing, sir. Please cooperate. So people like this type of single answers, so they'll carry into their brain. Number one, which flexible ureteroscope for your routine RIRS you will recommend? No conflicts of interest. Predominantly, Indian 50% of the urologists work in peripheries. They want cost-effective scope as many cases as possible. As of now, what is the cost-effective long duration scope, sir?
I think Biorad has got the highest.
Yeah, Biorad. Do you think 6.3 French will come in future and will be utilized more, sir?
Correct. Yes, there will be further miniaturization. That's what I think.
What is your laser settings for dusting in holmium laser, sir?
So in holmium, I start with 0.5 to 0.6 joule, and for the frequency, it will be somewhere between 15 to 25 in case of kidney, and very long pulse duration for the dusting. If I want to fragment, then in that case, my joules will be somewhere close to 0.7, 0.8, and I can go up to 1 joule or maybe a little more, and the frequency will be around 10, and short pulse duration in case of a fragmentation, in case of a holmium. So total power, I do not exceed more than somewhere between 10 and 20 watt in case of a kidney with a holmium laser.
Unmute, please. Unmute. Next question, sir. Do you feel that anytime have you used 150 micron laser fiber? 150 micron laser fiber. Do you use? Unmute, sir. Unmute, sir. Because we unmuted. Everybody we unmuted. Yeah.
Okay.
Do you use 150 micron laser fiber in TFL?
Yes, I have used many times actually in many demonstrations. But that is available at this moment with IPG only.
Please unmute. Again, you are talking. Please, somebody unmute. Okay, sir. Sir, I have seen you not so favoring fragmentation and popcorn. You always try to be taking a small, medium-sized stone appropriate to RIRS, and you do powder. Even in fans, you feel that the powder should come out and the last part of the fragment should come out. Is it the correct way to do RIRS, as many seniors like Oliver Traxler do the same?
I think I'm in order to produce good results, I think I would like to stick to this policy at the moment.
Sir, in the inferior calycial stone, watch what makes you that I don't do case today. You go inside, you thought that you will do the case, but what makes you that I don't want to do, let's do PCNL.
Oh, so I think the lower calycial anatomy has already been described by one of the speaker.
Sir.
So if a stone is very, very large, I would not like to go for a lower calycial stone RIRS with a large
Very
stone.
good, sir. Very good. And do you think that if the stone is not seen in toto, broad base is there, that is also risky, or you can slowly start fragmenting and getting them out?
Oh, if the anatomy is comfortable, I will go for
You will
that.
go ahead.
Yeah, I will go ahead.
For a beginner, do you think that large lower calycial stone should be avoided?
Yes, correct. Absolutely correct.
Absolutely correct. Sir, access sheaths, which access sheath is long, durable and comfortable? Which company you use?
At this moment, I'm using, I think, Blue Neem. Yeah, Blue Neem. That is 9.5, 11.5 ureter access sheath I use.
Yes, sir.
Up till now, I was using Rocomed.
What is the standard length of the access sheath you use, sir, routine RIRS?
Yeah, so I use 35 centimeter, both in men and women. But I think sometimes if I look at the length of the height of the patient, if the patient's height is more like 6 feet, then I go for 45 centimeter. The point is that the tip of my ureter access sheath, if I'm not using a fan sheath, should be below at least 3 centimeter below the UPJ, so that I can have a good deflection in the kidney.
Sir, maximum operative time you will look for, sir.
So somewhere between 60 to 90 minutes, I think that is the period I use.
But if the access sheath doesn't come 1 hour to 1.5 hours, if the access sheath doesn't come out easily after 1 hour of surgery, what are the tips and tricks you will tell, sir?
Okay, so first thing is that to avoid this complication, so if the ureter is too tight, don't try to push your ureteral access sheath. Your ureteral access should glide into the ureter, then and then you use a ureteral access sheath. That is one. Secondly, the ureteral access sheath should not be overused many times. Otherwise, you will lose that lubrication and then you will make yourself difficult. Third, do not exceed your operating time beyond, I think, 1.5 hours or 2 hours. I think that will be, then the access sheath will stick to the ureter. If it doesn't come out, just tell your anesthesia. I mean, always operate in general anesthesia. Spinal anesthesia, not a good anesthesia for RIRS for me. Then tell your anesthesiologist to
Yes, sir.
give a deep
Sir,
sedation.
ideal lubrication which you use, water or gelatin jelly for the?
Of course, water.
Of course,
Jelly
water.
should not be
One
used.
question. Jelly should not be. That's also one factor. Sir, in case of aspirin clopidogrel, if the patient is there for stone disease, most of the times I stop. You stop for 4-5 days, or you do?
Yes, I certainly stop because I believe that in RIRS, if it bleeds,
yes,
you have no way to stop it. So better to avoid bleeding in RIRS. So if possible, please discontinue clopidogrel and aspirin. Sometimes with aspirin 75 milligram, I have done RIRS, but not with clopidogrel.
Not with clopidogrel. Sir, if you are wanted to incise the infundibulum of the diverticulum or a diverticulotomy, is there any specific clock position, or you will cut small?
Yeah, I will cut small because there is no specific defined area where you can make a cut and you are sure that there are no blood vessels. So make a small, very small incision, multiple
Do you
incision.
think do you think that 3 o'clock, 9 o'clock separate laser fibers? I have not purchased like that. I am always 9 o'clock. Do you think that practically you got away just because you have another scope?
I think if you have both the scopes, I think it is good. But majority of times 9 o'clock is fine. It works. But if sometimes the 3 o'clock position accessory, the accessory channel position, sometimes it helps. Yes.
Sir, in RIRS fitness test, one important question asked by surgeon Satish, as expected. It's a good question. Those who are going for army and pilots, if there are inferior calyceal stone and you try to clear everything, and suddenly they come with failure with saying that CT has 4 mm stone, will you give guarantee to them, or will you say that it can still have residual stones?
Sorry, I didn't get the exact question.
Sir, those who are going for pilot job,
Okay, pilot job. Yeah,
they need 100% clearance. If
Yeah.
you cannot give 100% clearance, if you feel that on table it is there, but in the CT shows 4 mm stone, what can we do, sir?
So there cannot be any 100% in medical practice,
Yeah.
So that you can try your best, What if you can remove, you can remove. If you cannot, you cannot.
Sir, much debated question, urine culture sterile. All the urologists, to my knowledge, 90% do on the day of surgery. They may have the urine examination. Even sometimes I do without culture sterility. Forget about the theory, sir. In practice, when you get the case unbiased, will you do directly, and especially in non-diabetic, not risk factor patients? You can do?
Given a choice, Chandramohan, I still stick to the books, and I do urine culture in every single patient before taking for RIRS. Even if the patient is non-diabetic, even if the count is normal, even if the patient does not have fever.
Okay, sir. You will do culture. You will do
I
culture.
will do culture. I will do
Sir,
culture.
if
If possible,
intrarenal
yes.
pressure is raised, what are the signs you will feel that something is happening not good in your surgery? What are the points, sir, with your experience?
So I think practically speaking, supposing when you are doing a procedure and if everything is clean and suddenly you start seeing the oozing, you don't find any reason for that particular oozing, that time you have to understand that your assistant is pushing the fluid with a little more pressure than desired. And then
last question.
Yeah.
Last question. Do you think that your friends, you have done robotic surgery, RIRS in your workshop, and you have gone to Korea, and Sancho is doing a lot of robotic, but last 10 years, robotic urology, everybody laughs. Why can't we do half an hour, 1 hour? That also you need robot. Do you think that 75 lakhs as of now robotic, if it is there, even in future, if it comes for 20 lakhs robo, do you think that the people will be liking to buy it? Last question.
I don't think it's necessary to have a robo for the stone at least, and don't spend this much of money. I will not spend.
Yes, sir.
But in future, as you say that if the robo is available for 20 lakh, people may buy it just for the show off, because you want to be the first to buy a robo, and some people will buy it.
Okay, sir. So now we ask Dr. Nerli sir. He is sincerely listening. Initial part we could not take. Sir, Nerli sir, being the president of the ASU, will give a conclusion remarks. Of course, I give vote of thanks, but let sir say some words of wisdom, sir. Unmute, sir. Unmute, Rajendra. Yes.
Good evening once again. I think this was one of the best sessions which I had to see. There were a lot of young speakers who spoke from their experience, and I think the future of urology is very bright with all these youngsters taking a leading part in RIRS. Thank you very much.
Thank you, sir. With this, all the now still 89 people are there. This is the largest attended ASU conference. 214 have attended. So I thank Dr. Manohar, Dr. Satish, Dr. Deepak, Dr. Rajnikant for moderating. Special thanks to Kandar Parikh sir, who was there for 2.5 hours. His time is very much valuable. He's very senior, experienced, and patiently was listening without disturbing anybody. Even I was disturbing, but he was not disturbing. And Dr. Kiran, Dr. Deepak Raguri, Dr. Bhargavardhan Reddy, Dr. Narendra, Dr. Manasa T, Dr. Edikula Varghese, Dr. Rakesh, Dr. Jaya Murugan, Dr. Rajnikant, Dr. Syed Jahid Jara Raja, Dr. Raja, Dr. Braishwaran, all the audience. Thank you once again for having the ASU. Next month, we are having one more webinar similar ASU on BPH treatments. These online webinars will be recorded. They will be in ASU website. So those who have not completely listened, you can go back and listen if you are interested. Particularly, these are useful when you are preparing for the PG exam, or when you want to go back and present yourself. You will take all these slides and you will make your own one. That is the intention of online webinar. Thank you very much. Thank you, Kandar Parikh sir. Thank you,
Chandramohan, for the opportunity. Thank you, ASU, and thanks to all my friends. Thank you very much.
Thank you.
Thank you, sir. Thank you. Good night.
Thank you, sir.
Thank you, everybody.
Thank you, sir.
Manohar, thank you. Deepak, thank you.
Thank you, sir.
Thank you, sir. Thanks a lot.
Too much time it took. Actually, I might have made 8 presentations, but I involved youngsters. It's okay, no problem.
That's fine, sir. That's fine.
Lot of attendance was there. Lot of attendance was there.
Yeah. Very surprised to see so many people actually.
224 is too much.
Big number.
Big number
Very
for
big
an
number.
online webinar.
I didn't expect.
Yeah.
Especially. Great job, sir. Great. Thank you. Thanks a lot.
We'll leave the show then. Thank you. Good night.
Sure.